Institute of Fetal Medicine, Kolkata, it gives me immense pleasure to welcome you all to the annual day of IFM. Good evening, ladies and gentlemen. I welcome Dr. Rtna Duapuri ma'am, distinguished faculties, ladies and gentlemen. To have a child is a very basic instinct of all living beings, and humans are no exception. What is important is not only to have a child, but to have a healthy child. This is not only important to the family, but also to the society as a whole. I would like to call upon Dr. Seetha Ramamurthy Pal. Seetha ma'am koi? Chairperson of the prestigious Fetal Medicine and Genetic Committee of Foxy, President-elect of SFM Bengal, currently the Honorary Treasurer of BOGS, and so on. But most importantly for us, she is a member of the IFM family. I request her to take over the scientific proceedings.
Thank you.
Before that, ma'am, I would like to felicitate you. Clap. आपको चाहिए आपको
Thank you, Daljit, for the kind introduction. That's fine. Thank you. So, welcome one and all to this annual day function of the Institute of Fetal Medicine, and for yet another scientific extravaganza where we have none other than Professor Dr. Rtna Duapuri to give the important talk today for the scientific session, which will be followed by sessions or experiences from the students of Institute of Fetal Medicine, followed by an interactive discussion about some practical scenarios that we face, interspersed with the inauguration in between. So without any further ado, may I please, if I can start the first session, which is an important session which we deal with on genetics in our day-to-day practice. And for this session, may I please invite our esteemed chairpersons on the dais. May I have the next slide, please? Professor Dr. Basudeb Mukherjee. All of these people are esteemed in faculty in their own way, and none of them need any introduction. But if I may say a few words, Basudeb Da for us is the past president of BOGS, Bengal Society, is the director of Ankuran Fertility and Fetal Medicine Center, past chair of the Public Awareness Committee, Foxy, past secretary of the Indian Menopausal Society, Kolkata chapter, and past president of the Indian Endoscopic Society. As we all know, despite his multifaceted personality of varied interests, he also has interest in public awareness programs, vaginal surgery, menopausal health, and of course, Bengali drama and theatre, which we all always look upon on him. Thank you, sir, and welcome to the... Thank you. May I ask... felicitate? Can I please ask Deepanjana to felicitate Basudeb Da? Thank you, Deepanjana, and welcome, sir. Next is none other than our Mumtaz Di, Professor Dr. Mumtaz Sanghamita. She's also been the past president of our beloved Bengal Obstetrics and Gynecological Society, past vice president of ISOPAB, that is the Indian Society of Perinatology and Reproductive Biology, and IMA Bengal branch of past vice president, former member of the Senate, University of Calcutta, former HOD of the well-known Eden Hospital Medical College, Calcutta, from where a lot of her students have trained and have come up in a big way. And she has been national level examiner with special interest in obstetric ultrasound and fetal medicine, has inspired a lot of people here with obstetric ultrasound and fetal medicine. Thank you, madam. And may I please call Dr. Girija Warrior to felicitate Mumtaz Di. Thank you. Thank you, Girija. Girija is a very active in Institute of Fetal Medicine and a radiologist herself. Next we have, can we have the slide of Dr. Bani Kumar Mitra? Again, a personality who doesn't need any introduction. He's a senior consultant, reproductive medicine and gynecology at the Surgery Center, Kolkata, West Bengal, and a very renowned infertility specialist. And he's expert in himself for infertility and recurrent pregnancy losses. And his focused approach is very popular for his appropriate treatment based on specific indicators and focused approach in formulating low-cost treatment protocols. Thank you, Bani for gracing this occasion. Welcome. And may I please invite Dr. Emily Banerjee, Genetic Counselor at IFM, to felicitate Bani. Oh, that's okay. Thank you. Thank you, Dr. Emily. And last but not the least, Dr. Kamal Chandra Oswal, sir, very known, very popular and very renowned teacher here at the IFM and all across for ultrasound. And he's a consultant, senior consultant radiologist at the Ramakrishna Seva Pratishthan and NCS Diagnostics and Institute of Fetal Medicine. Welcome, Oswal, sir. And may I please invite Dr. Ashita Srivastav, who's now a fetal medicine specialist of Patna, but a student of Institute of Fetal Medicine, to felicitate Kamalda. Thank you. Thank you, and thank you, chairpersons. May I please hand over the session to you and hand over our esteemed speaker for the day. Thank you.
Good evening, friends. We're all waiting for this prestigious lecture by Dr. Rtna Duapuri. A short, very short introduction. Professor in Genetics and Chairperson, Institute of Medical Genetics and Genomics, Sir Gangaram Hospital, New Delhi. She's MD, DM in Medical Genetics, and she's from Lucknow. Dr. I.C. Verma, Outstanding Researcher Award 2019, Dharamveer Award of Excellence 2010, Young Investigators Award, Tokyo, Japan 2006, and memberships of Undiagnosed Disease Network International of NIH USA, Diagnostics Scientific Committee, International Rare Diseases Research Consortium. Panel of experts of WHO Collective Global Network for Rare Diseases International, ongoing research projects, Indian Undiagnosed Disease Program, establishing a registry for rare and potentially treatable genetic disorders, artificial intelligence and genomic profiling and diagnostic yield, molecular characterization of lethal skeletal dysplasias, sequential evaluation of patients with muscular dystrophies by deep phenotyping and molecular studies. More than 140 publications, and we are all eagerly waiting, madam, to hear you. And it's a very practical approach to this difficult subject. I welcome Dr. Duapuri to come over here and take the mic, please. Thank you.
Seetha ma'am to please felicitate her.
I have no chance.
Good evening, everyone, and thank you very much to our chairpersons for such a kind introduction. I'm actually privileged to be here. It's been a long journey. You'll hear about it at the end of my talk, but I'm really happy to be here. And at the outset, I would like to thank Dr. Ghosh and Dr. Daljit for making my stay so comfortable, for inviting me here, and asking me to speak on this subject very close to my heart, which is incorporating genetics and genomic testing in obstetric practice. I'm going to show you 5 scenarios. I've broken down everything into 5 rules so that it's easy to remember what is very, very important by the bedside when examining a patient. And I think I start with something we all are great at, but we forget in this huge era of tests and the maze that surround us, and that is a simple conversation. And this really goes by saying what information can be ascertained from the cheapest intervention, and that is a good family history. So if you see here, this is a lady who came into the clinic in her 5th pregnancy. The first was a miscarriage, the second is a daughter who's well. The third was discontinued in the 3rd trimester for renal agenesis because there was a cardiac loss of activity because of oligohydramnios. The second in the 19th week, we don't know what was there, but it just said abnormal ultrasound, but there were some anomalies as per the history. And in this particular pregnancy, there was an ecogenic intracardiac focus, which is really not relevant on its own, but there was an ecogenic bowel, there were short, long bones, and there was a midline cleft palate. So what do we see here? That there are major malformations in the form of renal agenesis and cleft palate. And we have in the same family, although in different fetuses, but that doesn't matter, different organ systems that are involved. And therefore, this is the biggest clue to a genetic etiology. So this is just information at a glance by drawing a simple pedigree, and we need to obtain as much as information as possible to assess what is the reproductive risk. And then it's actually there always in the case as a ready reference for management. Let's come here, something which is very important in every part of our country, but more so in Calcutta, because we know this is a belt where hemoglobin E is very common. And therefore, every pregnant lady must be tested not only with the hemoglobin A2 level, but along with that, a hemoglobin, a MCV, a MCH, and an RBC count, because you need to see the full picture in totality. Look at this pedigree. They came in pregnancy for short, long bones, but everybody missed this. We looked at the father was short, and then he told us that my first baby died in the neonatal period when we were transferring him from hospital A to hospital B, and we don't know why. And then when we went on further, he had a brother who was short. Both his children of the brother were short, as was his mother. So what is happening here? This is a family history of short stature. And then when you go and examine this a little further, you realize that this is a non-lethal skeletal dysplasia, which is cleidocranial dysplasia. And why this, which is autosomal dominant? So much information from a history and examination. We hadn't touched an investigation. And this child had died because in cleidocranial dysplasia, the skull bones are not formed. So when the child was being transferred from hospital A to hospital B because of prematurity, there was an intracranial bleed and the child died because of that. And therefore, when we counsel them, in this there is an absent clavicle, which this child also had. And when we counseled them, they said, we are fine, all of us are okay, because they're just short and intellectually they are absolutely fine, they have no disability at all. And the pregnancy was continued. So much information without sending a single blood test, but that's all it required. Now we come here. This is a lady who came because her brother had what we always referred to as in the days gone by as polio because he had problems in walking. But when you take the family history, you realize that it's not polio. This is an X-linked disorder because there are males who are affected through carrier females, and somewhere down the line there was a history that her sister had also had a baby who underwent prenatal diagnosis. And because these are genetic disorders, we are not happy to share them with our siblings because we feel that, oh my God, there's something not so good in my family, and therefore she had not shared it with her sister that this is the disorder in our family and you must check. But this all came out in the family history, and then we are able to help them. And the last is multiple individuals affected in the same generation. So this is in a vertical line in multiple generations, but males and females both. This is multiple generations, but only males and through a carrier female, so it is X-linked. This is a single generation, which is autosomal recessive, but this is a rare situation where in a single generation we have multiple children affected with Down syndrome, something we never see, and also miscarriages. So not a single child who's normal. And this is the only one situation of Down syndrome where there is a 21-21 piggybacked onto each other. So this is 3 21s, but 2 are piggybacked onto each other as a 21-21 translocation, and one of the parents is a carrier of a 21-21 translocation. Now, finishing with that, how do we ascertain things? For example, in this pedigree, as I had talked about, an X-linked pattern of inheritance of a muscle disorder, most common in our country, and all over the world, it's Duchenne muscular dystrophy, which affects boys with an incidence of 1 in 3,500. We first, for this lady who has come in the clinic, have to ascertain whether she's a carrier of DMD or not. There is a 50% chance that she's a carrier and a 50% chance that she's not a carrier. So once we have done that, by testing, only then you find out, well, here if a prenatal test was done, obviously the mutation in the DMD gene is known. So you check what this mutation is from the sister, and you check for that one mutation in this one or this one in the other sisters in the family, and if any of them are carriers, only then would you do prenatal testing. There is no rule of doing prenatal testing until this entire exercise is done. So therefore, the first rule is first visit has to be a 3-generation family history and more depending upon what the history is. Then we come to the second part of my talk, which is this is what the human genome is. We talk a lot about genetics, genomic testing. What does it mean? In every cell of our body, we know that there is a nucleus, and we know that inside the nucleus there are 23 pairs of chromosomes. Now, every chromosome is made up of this one single DNA double-stranded molecule, and if you unzip that chromosome, it opens up like this. Now, what is this DNA? The DNA is made up of 4 alphabets, A, T, G, C. And these happen together. You can see the different colored bars. These are coming together in different combinations in every chromosome of our body. And different ATGCs come together to form a gene. So essentially, it's all there in the nucleus of our genome. This is the chromosome that is enlarged. It has a P arm, which is the petit arm. It has a Q arm, which is the long arm. And it has these 2 limbs, which come together by a centromere. And then within this chromosome, remember I said this is the double-stranded DNA molecule, and these ATGC alphabets come together to form a gene. And therefore, we have, this is gene 1, this is gene 2. So in our 23 pairs of chromosomes, we have 20,000 genes. Now, every gene occurs in a combination because every chromosome has a pair. We have a total of 46 chromosomes. And therefore, these are the two copies or what we call alleles of the gene. And I've just given here an example of beta thalassemia. What does a gene look like? A gene has what we call exons, and it has introns which come in between the exons to hold them together. And these exons are the important parts of the gene. That's what codes to make a protein. Now, for beta thalassemia, we know that this gene has 3 exons. So all this information is known in the world. And therefore, we look for point changes. All these things that you see here are the changes from the normal in the beta thalassemia gene, which are called mutations. Because we've known about beta thalassemia for so long in our country, the mutation profile is well characterized. There are more than 300 mutations present all over the world, but we know that in India, 99% of the mutations are 10 common changes. So that makes life very easy for us, because 5 mutations account for 90% and the other 5 account for another 9%. And therefore, because it's a small gene, we understand and know so much about it, we do what we call just the sequencing of the gene, which is the name of the gene is the HBB gene, to understand what these mutations are. Either we sequence or we do a PCR-based test, that depends upon the laboratory. So what does this mutation mean? Remember, this is the normal reference of the chromosome. This is normal. Fine. Now, if there is a change in one of the A or the T or the G or the C compared to the reference, this is a mutation. Now, if one is normal and the other is mutated, this person is a carrier. A carrier never has disease, but just carries one mutation. However, if the other copy of the gene also gets a mutation, then there is no functional copy, and therefore for these autosomal recessive disorders, this individual who harbors these mutations will have the disease. And by rule, we say that for an autosomal recessive disorder like beta thalassemia, spinal muscular atrophy, the parents are carriers, and therefore there is a 25% chance that the baby will have disease. So now, coming back to beta thalassemia, let's come to this scenario 1. You see this family history, you see that there are 3 generations, 1, 2, and 3. And this is the lady who came into the clinic because she's pregnant. And she recently figured out that something is not okay in her family, because she has a nephew who has beta thalassemia major and gets a transfusion every month. And her husband also has a niece who has beta thalassemia major and also receives a blood transfusion every month. But you can imagine that in the first pregnancy, nobody asked them these questions, they were not aware. And as, they grew mature, they started Googling as to what's happening, and therefore they figured out we now need to consult somebody because of this family history. So we did an HPLC hemoglobin A2 along with the complete blood count of the couple. One was a beta thal carrier and the other was a hemoglobin E carrier. How do we do prenatal diagnosis here? We cannot do the HPLC in the fetus at 11 weeks. We have to wait for 18 to 20 weeks to take out a blood sample and do it. And that's not a foolproof test, because you can have false negatives there. So that's not the method of choice. The method of choice is to go back to that gene I just showed you, identify the mutation in the couple, and then test for those 2 mutations in the fetus. How do we do that? We know that there are 2 affected individuals. We just figure out whether their mutation profile is known. For example, the mutation was known here, and we know that this sister has a specific mutation which is C.51 del C. You don't need to understand these words. And therefore, her brother may or may not be a carrier. And so we can just check for this, because his A2 is raised, he will have this mutation. Whereas the hemoglobin E, which is high in this lady, her nephew also has hemoglobin E. This would not be homozygous. He was a carrier with beta thal, because hemoglobin E homozygous is not a disease. And therefore she is a hemoglobin E carrier. And we know that now, because both these partners are carriers, there is a 25% chance that this baby could have E beta thalassemia and a 75% chance that the baby would be normal. Now, E beta thalassemia can be a mild disease where the baby is absolutely fine, and only at the time of puberty or at extreme stress there can be a fall in hemoglobin and requirement of a blood transfusion. Or it can be a severe disorder like beta thalassemia major, and by about the end of the first year of life require regular transfusions lifelong, once every month. The challenge is that in pregnancy we cannot predict the phenotype. Okay, we can only say, does the baby have beta thalassemia or E beta thalassemia or not? And then it's the option of the couple what chance they would like to take for their baby. It is not for us to choose. And I think it's important to explain this to the families whilst we are doing a prenatal so that they can make an informed choice. So, for the prenatal, all that has to go into a pre-test counseling. Then if the couple opt for prenatal diagnosis, we are armed with this information of the mutation profile. We take a CVS sample and just do a targeted test for these two mutations. And that is what is important to understand. And unfortunately, the fetus was affected and a compound heterozygous for E beta thalassemia. So, when you know anybody in the family and the mutation is known, for the person who has come into your clinic, you will only do the targeted mutation profile. You don't need to do big test and reinvent the wheel, because these targeted tests are cheaper and because they are targeted. So the exercise of finding the needle in the haystack has already been done for some member of the family, and the mutations run true in the family, and therefore we just do targeted testing based on what the mutation profile is in that family. So rule number 2 is that beta thalassemia screening must be done for all pregnant couples. Whether we do it for the lady, you do it for the couple, it doesn't matter. But there is the National Health Mission document for beta thalassemia that makes it mandatory for beta thalassemia screening in India. Then we come to the second scenario, where this lady came in pregnancy because her first child, a daughter, had intellectual disability, and she was referred for prenatal diagnosis of intellectual disability. Now, this is not possible because intellectual disability is a phenotype. It's like fever. It can happen because of one of so many reasons, which could be genetic, teratogenic, or non-genetic. And therefore, first we have to ascertain, why does this child have intellectual disability? So you start with a physical examination. After the history, we start with the physical examination of the child, and because we saw a large number of neurocutaneous markers, we had an MRI done. And the MRI was absolutely telltale for a disorder which is tuberous sclerosis. Then we looked at the parents, because tuberous sclerosis can be either happen by chance in the baby, or it could be inherited from one of the parents. And then when we looked at the mother, we saw these telltale signs of these angiofibromas on the face, these little pits here as well as here. So, and her intellect was normal, but telling us that the mother had also tuberous sclerosis, so we color her now, and her child also had tuberous sclerosis, but the mother was intellectually normal, but the child had severe intellectual disability along with all these neurocutaneous markers. Now, this is very common with autosomal dominant disorders that run in families, because the phenotypes in different affected individuals in the same family can be different. So you can imagine how challenging counseling is here, because her next baby may have absolutely normal intellect or a severe intellect. And again, we cannot predict the phenotype in the family. So now the lady says, okay, I want a prenatal diagnosis for TS. How are we going to do that? We cannot test the fetus directly again. We have to test either the mother or the child. And how do we go for that? Tuberous sclerosis is a disorder that can be caused because of mutation in any one of two genes, TSC1 and TSC2. Now, these are all these little things that you can see, these dots and crosses and triangles, are different mutations that are present in different individuals with tuberous sclerosis. Unlike beta thalassemia, there's no common set of mutations, unfortunately. And it's a big gene. You can see these are all the exons of the gene compared to the 3 exons of beta thalassemia. But we do know from literature that mutations in the TSC2 gene are much more common than in the TSC1 gene. And this was in the era gone by when we didn't have such easy genomic and testing. So we used to sequence every part of this gene in my lab. And so we sequence the TST2 gene, and you can see these are the ATGCs. You can see the 4 colors, red, black, green, and blue, depicting the different alphabets. And you see here that this is not clear because a little part has got deleted. One C, which is the blue, has got deleted. And it's that one alphabet which got deleted, which caused the disease in the mother as well as the child. Now, once we have this mutation, now we do a CVS because now we know what to target from this whole plethora of mutations. We cannot go digging in the fetus. We have to hit the target. And once we know that, we can counsel this family. So the rule 3 is you have to test the affected individual before prenatal diagnosis. And therefore, a referral is required early because the pregnancy doesn't wait for anything. The pregnancy keeps advancing, and therefore the patient, where there is a positive family history of a suspected genetic disorder, must be referred at the first visit. We come to the third scenario, where this lady came into the clinic. She was 40 years old, and she said, okay, I want screening for Down syndrome. So what are the options? We know the risk at 40 is about 1% to have a baby with Down syndrome, and 99% the baby will be fine. There are a whole menu of screening options, which we will be discussing later in our heart-to-heart and common talks. You can do it in the first trimester. We know the combined first trimester screening. You can do this prenatal cell-free DNA screening, which is the NIPT or the NIPS, or in the second trimester, you can do quadruple. But what is important is you have to do only one screening modality. There is absolutely no role of first doing a first trimester screen and then individually doing a quadruple screen. Either you do a sequential or a contingent, but no doing the 2 screens independently. Or they would want a diagnostic test, which is either an invasive CVS or an amniocentesis. And if they want directly to do a diagnostic test, then there is absolutely no role of doing a screening for aneuploidy. Now, this couple came in and we saw that this girl was not absolutely normal. And then we started wondering that what is happening here. Her amniocentesis had been done. And the mother had said that, yes, my daughter who's 13 has intellectual disability, but she's been evaluated and everything is normal. And then we believed her, didn't see any notes, until when we were doing the karyotype in this, because this was a low-risk case, so we were doing a FISH and a karyotype, we identified something abnormal in chromosome 3. And then we called her back, took the blood of this child, and again we found that she harbored the same abnormality that was present in this fetus. So although this fetus did not have Down syndrome, the fetus had the same problem as this girl, which was a 3p plus syndrome. That means there was an abnormal chromosomal element present on chromosome 3 in this family. And the mother had forgotten this information because her daughter was 13 years old. Now, so that's the 3p plus. You can see that while we test by FISH, just for these chromosomes, we would have missed if we had not done a karyotype. So never do an invasive test and give incomplete information to the family. Combine it with either a karyotype or a microarray, even though the family says no. But I think it's for us to make the families understand that there is a lot beyond Down syndrome. Now we talk a little more about chromosomes, and that is, this was the standard chromosome or the karyotype as we call it, which we've been talking about till now. Now we have a technique where we can look at this with a magnifying glass so that we can see little dots that are either duplicated or deleted. These are called microdeletions or duplications, and it's just like looking at this karyotype with a magnifying glass and seeing each level of the P and the Q arm like these dots, and then seeing is something missing or is something duplicated. And I take you through scenario 4 for this. So this was a primary gravida. She came for an increased nuchal translucency, which was 4 millimeters, and obviously with this sort of NT, the first trimester screen would also be positive. And so therefore, we have an NT which is more than the 99th centile. You synthesize the information that's associated with this. It could be a genetic disorder, it could be a structural malformation, it could be an advanced pregnancy outcome, or the baby could also be normal. Every increased NT is not does not mean an abnormal baby. Should we do a first trimester dual marker? Not required. Is there a role of invasive testing? And if we do that invasive testing, from this whole menu of genetic tests, which test should we do? A FISH, a karyotype, a microarray, a QF-PCR, or an exome sequencing? Or should we just say, oh my God, the NT is 4 millimeters, it has a very, very high risk for Down syndrome, you just abort the pregnancy? The last is absolutely incorrect. You have an array of options. You should do, after counseling, the family chorionic villus sample, because this is in the first trimester, look for maternal cell contamination, and then look at the chromosomes in detail. And the guidelines today suggest that we should do a microarray after testing for maternal cell contamination. And when we did a microarray on this baby, we identified this little dot on chromosome 7, which on the karyotype looks normal, but when we do an array, we find that there is a big duplication. And this is associated with an intellectual disease phenotype along with behavior abnormalities. So we see that there is a 1.4 million bases, 1.4 million ATGCs that are duplicated in this little dot of chromosome 7 in the Q arm. If we had just done a karyotype, we would not have picked it up. So one of my students had done a little study during her DRNB training on fetuses with increased nuchal translucency and followed them up for 3 months after birth. This was published in the Journal of Fetal Medicine. This was before the era of a lot of microarray. This was just in the beginning of microarray. And she had 282 patients. We divided them into 2 groups of an NT between the 95th and the 99th centile, and group 2 was more than the 99th centile, which is 3.5 millimeters. And you can see that in both groups, after looking at chromosomal abnormalities, structural abnormalities, adverse pregnancy outcomes in euploid babies, we still had a take-home live birth rate of 70%, of 77% and 43%. So testing needs to be done, and not just discontinuation of the pregnancy because there is a structural abnormality on the ultrasound. Lots of committees now say that chromosomal microarray is the test of choice if the fetus has one or more structural abnormalities and is undergoing a prenatal test, because it provides greater information varying from 3 to 10%. You can also do it for any structural normal fetus who's undergoing invasive testing, say for a prenatal diagnosis of DMD or for a positive first trimester screen in a normal, structurally normal fetus. And third, it has utility where you want to do a genetic test for intrauterine fetal death or stillbirth, because it's a more robust test than karyotype. Karyotype requires dividing cells, which can be a challenge to find in the last situation. So there's a lot of confusion about NT. Should we just stop at microarray? Should we do beyond microarray and look at all 20,000 genes? And I thought today I'd take this opportunity to review a little bit of literature and bring it forward. So what is increased nuchal translucency? World over, it's 99th centile, which is 3.5 millimeters. So this paper, which was published in the Ultrasound in OB-GYN, said increased nuchal translucency, you do a normal 16 to 18 week scan and the fetus is normal. We do a microarray because that's the standard of care. You get a yield of 3 to 4% over a normal karyotype. Okay, so that's the advantage. But when they looked at the 20,000 genes by exome sequencing, and I'll come to that in a minute, there was a diagnostic yield of 4% for pathogenic and likely pathogenic. So every word I'm saying has a meaning. For pathogenic and likely pathogenic variants, because there were 15 of them in a cohort of, I think, about 304. So this was a meta-analysis where they reviewed 11 studies. And now the whole issue is, so we agree CMA has to be done. After a CMA, should we do further testing? And if we have to do further testing, what do these words of panel, exome, and NGS mean? So we come back to this diagram over and over again. We said that within these 23, within this double helix are the ATGCs, and these are the exons of the gene. And all these exons make protein. Now, within our human body, in the 23 pairs of chromosomes, there are 20,000 exons. These exons is the exome, but that only constitute 1 to 2% of everything that we are made of. We are made of what is referred to as the genome. When we take this little slice that you can see here, the 1 to 2%, that's the exome. There was an era that we thought that this 98% is junk DNA, and we used to call it like that. When I was training, we used to say junk DNA, let's just focus on the 1 to 2% of the exome. But today we find, I run a program which is the Undiagnosed Diseases program in India, and we only take in patients who've undergone exomes and undergone arrays and the world, and for 10 years they've been working for a diagnosis of a genetic disorder, and we are doing genome sequencing and analyzing. And now we are understanding that this genome is not junk DNA. It's a lot of regulatory activities which is also important for the functioning of these 20,000 genes. But because we are still understanding the genome, it's still on a research. So no genomes in the fetuses in our country as yet. Then we come to the exome, which is just this little square of the genome for 20,000 genes. And then, so exomes are done routinely in postnatal life. So if I have a child in front of me, I examine the child and I decide, okay, I think it's this disorder, let us do an exome to understand the gene mutation. We have another test which is called a gene panel, which again is just a little slice of the exome because it's just a panel of the 20,000 genes. How do I decide that? If I have a phenotype of a neuromuscular disorder, supposing it's fetal akinesia, dyskinesia on your ultrasound, I could run just a neuromuscular disorder panel because it deals with only those genes which are related to that phenotype. And coming back to nuchal translucency, we talk about a group of disorders which are referred to as rasopathies because the commonest one here is Noonan syndrome because of a PTPN11 gene mutation, but now we know 18 genes can cause a phenotype of Noonan, and that group is called rasopathies. So what is the advantage of doing a panel over an exome over a genome? Of course, the genome will give us more information, but it gives us more rubbish also. And we are not able to sift out the rubbish from the clarity. So if we test less, we get more clarity than testing more and getting more rubbish, even though we may get a little more information. And because in fetal life, we don't understand the fetal phenotypes of disorders that manifest in afterbirth, and the fetal phenotypes can be very, very different from the postnatal phenotypes, we think it may be better to do a gene panel or an exome, but never a genome. And analysis of these has to be very, very meticulous. So, it's just what I've just explained. You do a panel, which is either a panel or a clinical exome we do is also like a panel, to simplify interpretation and minimize the number of inconclusive findings we get when we analyze the data. And I don't know whether you caught here or not, we get 5 million variants when we do a genome. These are variants, means they are different from the normal sequence which we take as a reference sequence. We have to sift out from the 5 million, which is that one which is causing disease, and believe me, it's not an easy task. When we do an exome, we get 70,000 variants. So that's why we have to be very careful on what we order and how we interpret, because every variant that comes in the report is not disease causing. Pathogenic, likely pathogenic, remember we come back to those words. Those are disease causing, but let me tell you, 10% of pathogenic and likely pathogenic variants are found in normal individuals. So you have to be careful. Whereas we have variants of uncertain significance, which at that point in time, there is no information world over whether that variant is disease causing or not. So coming back to the question of increased nuchal translucency in this study, there were 11 studies. Out of 309 patients, they found only 15 with pathogenic and likely pathogenic, so that came out to about 4%. 40% of these had a high nuchal translucency. The rest had a nuchal high means there is a thought, should we take it above 5 millimeters and then do an exome, or should we do it even between 3.5 to 5? So if you go by this, well, you would miss 60%. There was one large study in that of 73 fetuses. They found 4 abnormal. This was the study with the maximum number of abnormal fetuses. But they also found that 3 of these 4 at 18 weeks developed structural anomalies. So should we really be doing a CVS very early and killing ourselves with the burden of variants of unknown significance? Because if we actually come back to our first line of a normal ultrasound and a fetus with no structural abnormalities, it was only 1 of 73%, and your yield goes down from 5.5%, which sounds scary, to 1.4%. But let me tell you one thing, that we may do any number of tests. There is no way that we guarantee that the fetus is normal. I have a child with a genetic disorder, 100% stamped that it's a genetic disorder in postnatal life, and I have a diagnostic yield of just 40%, doesn't matter what genomic test I do. So I think this kind of background information is important because it helps us to counsel families that we are not here to stamp a normal baby. We can't. But 99% of the babies are fine. Okay, let's say 97, because in every pregnancy there remains a baseline 3% risk. If you do the test, you can decrease the risk to 1% or 2%, but you can never make it 0%. So what should we do in India? Why can't we follow the guidelines of the US and the UK blindly? Why? Because we don't have a normal reference sequence for the Indian population. We are still struggling. We were not part of the consortiums when they were sequencing normal individuals. India has now started the genome sequencing of normal individuals, and until we get the normal sequence, we don't know how to interpret the data that we get. So therefore, these variants of unknown significance will remain variants of uncertain significance until we have good reference sequence data. And if we continue to do discriminate testing and terminating WOOS babies for Wu's variants, we could be discontinuing a large number of normal babies. And I think that's very important not to do, because here we are doctors, we are here to save lives. And therefore, it's important to remember that synthesize information appropriately. You have to go into the depth of a study. It doesn't work by just reading one figure somewhere. To allow correct use of a genetic test, because one jacket doesn't fit all. Now, I come to my last scenario, which is, we see, this was in my hospital, 2 babies, pregnancies discontinued, autopsy done, exome done, genome done. They had agenesis of the corpus callosum and a hypoplastic cerebellum. When we did the exome, there was a Wu's variant in a gene that causes Donnai-Barrow. And then I say, okay, if I fit the phenotype to this gene, I can make this likely pathogenic. I can fit any phenotype to anything, because if you search literature, you will find one case which reports agenesis of corpus callosum and hypoplastic cerebellum. But that's not correct. We didn't get anything. We just continued doing scans and I'm sorry, we don't have an answer. We think it's genetic because it's happened in 2 babies. And then you start thinking, is it just, I actually had these thoughts. Are we discontinuing a baby? Maybe it will come up later in gestation. That time 20 weeks was the deadline. So those thoughts went through. But ACC, I can say, okay, wait for another 2 weeks, but maybe not the cerebellum. But I always feel that the human body is not 1 + 1 is equal to 2. 1 + 1 is never equal to 2. It's always an odd number. Then what happened? Then we've identified many other families in India with the same phenotype and identified a gene mutation which explained the hypoplastic cerebellum and ACC in all these families. This was a gene which was known to cause a different postnatal phenotype, what we call a neuronal brain iron accumulation disorder, but was now identified to have a prenatal phenotype of pontocerebellar hypoplasia. So remember, it is very important not to push a diagnosis. Maybe at that point in time a gene is not identified, and 3 years later, as for this family, a new gene is identified which explains everything. So all pregnancies that are discontinued for major anomalies must have a fetal autopsy. Along with the ultrasound phenotype, a fetal autopsy phenotype is very important, and systematic genetic testing with correct interpretation. And I think the key lies here. We all have come a long way. We've learned the genetic tests. We've learned the basics of genetics. And now we have to focus on doing the correct interpretation. So to conclude, I left my home at 7 a.m. today morning, so it was a long way to Calcutta. I just reached half an hour before the meeting. But my messages in this presentation in the last 25 minutes have only been 5, and I think it's just important to conclude with those messages of the importance of a family history, the need for each of us to screen pregnant women for beta thalassemia, test the affected individuals, no direct prenatal diagnosis. We have to find the mutation in the individual with the disease in the family. If the person is deceased, then we find other ways of going about it. Synthesize ultrasound information to enable correct use of a genetic test. All pregnancies that are discontinued for major anomalies must have a fetal autopsy, appropriate genetic testing, and interpretation, because one jacket doesn't fit all. Thank you so much. We'll take questions in the end. Okay. Thank you.
We'll take a group of pictures. For that insightful talk on making such a complicated... Sorry. thank you once again for making such a complicated topic see so simple and in such a lucid way. I think it has enlightened a lot of the general obstetricians as to how exactly when to use, what to use the test, and how to interpret it. Can I have some few comments from the madam, if you can take a seat there?
Yeah.
A few comments, but we will entertain the questions at the end where we have an interactive discussion.
Actually, thank you for the very nice presentation. What Kypros Nicolaides started first with the chromosomal testing, the NT scan way back in the 90s. That paved the first way to direct fetal malformations. And then along with that, chromosomal studies came in. Now is the due of genetics, and we look into the genetic basis of a chromosomal or anatomic malformation. The advent of the NGS testing and the CMA has proved a long way.
Yeah.
So I think in the recent years to come, this will be going ahead and ahead, so much so that now we can do the NICS culture is a pre-genetic testing with blastocyst as also PGT to detect a lot of these, to prevent the formation of these chromosomal and genetic abnormalities. Thank you very much indeed.
Thank you.
Any questions?
Questions we'll take at the end.
Okay.
May I please invite Rtna madam for a group picture with all the chairpersons, and I please invite Dr. Ghosh and Daljit as well, please, to join in for a group picture. So we move on to the next part of the program, which is a short inauguration with lamp lighting. So to start off on an auspicious note, we always invoke the blessings of the Almighty. And to start off with this, may I please invite Dr. Basudeb Mukherjee for a small shlok in the memory of the Almighty, and to bless us all to continue our work further for the well-being of the woman and the child. Now,
Om Sarve Bhavantu Sukhina Sarve Santu Niramaya Sarve Bhadrani Pashyantu Ma Kaschit Dukshavaga Bhavet. Om Shanti Shanti Shanti. May all be happy. May all be free from illness. May all see what is auspicious. May no one suffer. Peace, peace, peace.
thank you, Basudebda, for that blissful shlok. As we remember always our Almighty in all our doings. Next we go on to the lamp lighting, and as we all know, lamp dispels darkness, and the light of knowledge never extinguish us. So may I please invite all the dignitaries, Professor Rtna Madam, Basudeb da, Geeta di, to light this lamp of knowledge. Kushada, please, of course, Kalida, Shojal da, Biman da, Pranab Das Gupta, all the dignitaries. Please, may I ask... yeah. Shojal da, please. If I'm missing anyone, Bulbul di, Mumtaz di, please. Join to da, you can also join. Shakti Rupati. Arubda, please. I didn't see you. Bhashkar Pal.
আগুনের পরশমণি ছোঁয়াও প্রাণে এ জীবন পূর্ণ করো এ জীবন পূর্ণ করো এ জীবন পূর্ণ করো এ জীবন পূর্ণ করো দহন দানে আগুনের পরশমণি ছোঁয়াও প্রাণে আমারে দেহ খানি তুলে ধরো তোমার ওই দেবালয়ে প্রদীপ করো আমারে দেহ খানি তুলে ধরো তোমার ওই দেবালয়ে প্রদীপ করো নিশিদিন আলোক শিখা জ্বলুক প্রাণে নিশিদিন আলোক শিখা জ্বলুক প্রাণে আগুনের পরশমণি ছোঁয়াও প্রাণে এই জীবন পূর্ণ করো এই জীবন পূর্ণ করো এই জীবন পূর্ণ করো এই জীবন পূর্ণ করো দহন দানে আগুনের পরশমণি ছোঁয়াও প্রাণে আধারের গায়ে গায়ে পরশতব সারা রাত ফোটাক তারা নব নব আধারের গায়ে গায়ে পরশতব সারা রাত ফোটাক তারা নব নব নয়নের দৃষ্টি হতে ঘুচবে কালো যেখানে পড়বে সেখায় দেখবে আলো নয়নের দৃষ্টি হতে ঘুচবে কালো যেখানে পড়বে সেখায় দেখবে আলো ব্যথা মোর উঠবে জ্বলে ঊর্ধ্বপানে ব্যথা মোর উঠবে জ্বলে ঊর্ধ্বপানে আগুনের পরশমণি ছোঁয়াও প্রাণে
Thank you. Thank you. Thank you all dignitaries, and thank you for that soulful rendition by Joita Datta, Dr. Emily and Upasana. And thank you Basudebda for joining in as well. Thank you so much. We now move on to showcase some of a lot of work that goes on at the Institute of Fetal Medicine. So and for that, may we have a short video of the activities that go on.
Welcome, ladies and gentlemen. IFM is a concept, it's a long-term dream come true. Fetal medicine was introduced in this part of the world way back in 1997. At the Institute, which we fondly call IFM, we have a dedicated team of ultrasonologists, geneticists, and pediatric cardiologists, as well as interventional ultrasonologists who are proficient in performing procedures like amniocentesis, CVS, multifetal pregnancy reductions, radiofrequency ablation, intrauterine transfusion, and so on. Today, fetal medicine is much more than just ultrasonography. We think of fetal wellness rather than illness. And we assess the fetus as a whole. Fetal medicine has grown over the years. It's almost like an old wine which has ripened and is fully matured now. Here we try to assess the overall health of the fetus and to ensure the parents that the unborn baby they are going to have is perfectly healthy. And in that, ladies and gentlemen, we need your blessings. And of course, we need the blessings of the Almighty.
IFM is not only one of the pioneer centers of fetal medicine in the country, but I can assure you, with IFM, you are in safe hands.
I started my journey with IFM around 20 years back, and from there now we have 4 ultrasound machines with a very high quality ultrasound machine, and I am really honored and privileged to work with Dr. Kushagradhi Ghosh. Since we have started the genetic counseling and the amniocentesis and CVS to diagnose the genetic disorders also. So again, in some patients with Rh incompatibility, there are options of doing the intrauterine blood transfusion, and seeing a lot of patients being benefited by intrauterine blood transfusion. And this gives us immense happiness and to serve the patient to our capability.
One of the very important components of the activity of IFM is training. Knowledge shared is knowledge increased, and we continuously believe that training the Gen Next doctors is our responsibility, and I hope the legacy carries on. Long live Team IFM.
that, I'd like to welcome Dr. Ghosh to say a few words, please. Thank you.
Good evening, ladies and gentlemen. Thank you, Seetha, for asking me to say a few words. I'm really overwhelmed. Overwhelmed is a very small word to say. To see all the known faces on a Sunday evening, because we all are very busy during the weekday, and it's only one day on a Sunday that we try to spend our time with the friends and the families at home, especially in the evening, in this chilly evening on a weekend. And that you have come, leaving that, to bless us, to be with us, to support us, to share our happiness and joy is a really overwhelming thing. It is not possible without the blessings of the elders, the respects and the love and the camaraderie that we have. Now, I won't take much time, but before that, I would really like to thank Dr. Rtna Duapuri for agreeing to come all the way from Delhi in this cold weather. And as you have heard already, that she was supposed to take a very early flight, but because of fog, that was delayed. And the flight took off, I think, about 4 or 5 hours later. And then she landed up at 3:30. So we were supposed to take her around Kolkata, because she said that she has visited Kolkata many times, but unfortunately she has not been able to go around in Kolkata, like many times things that happens with us when we go to conferences. But next time it will definitely be, I can assure you, and she's going to catch a morning flight tomorrow at 5:30, because she has a very important commitment at her hospital, Sir Gangaram Hospital, the Apex Institute. She's the best known clinical geneticist in India, I should say, and she's a mother figure of genetics. Now, I won't take much time. I would like just to introduce the team IFM over here. I want to give a long year. Now, before I miss anybody's names, I would like to call Professor Kamal Oswal. Where is Kamal? Yeah. Without him, this IFM wouldn't have been what it is today. I met him at RKM, and we were very young then, at 35, 36 years. We were at that point of time. He was in radiology, I was in obstetrics and gynecology, and I'd freshly come from there. I needed patients, I needed a machine to continue with my skills, and he was there in the radio diagnosis, and we set up the so-called fetal medicine unit at that point of time. Kamalda, without you, it would not been possible, really. I'm so very indebted to him. Next is Dr. Seetha Ramamurthy Pal. We are so fortunate to have the chairperson of the Fetal Medicine and Genetics Committee of Foxy and the president-elect of Society for Fetal Medicine, Bengal. Of course, BOGS, she's going to climb the ladder. At the moment, she is, what you are in BOGS? Treasurer. Yeah, treasurer in BOGS, because I've seen her as an MC member. So she's the treasurer now, and she's going to be the president very soon. Debashri Gangopadhyay, a very renowned pediatric cardiologist attached to Rtna Duapuri Hospital, who is attached to us, does all the neonatal and the pediatric fetal echo, and all the second opinion fetal echocardiographies which come to a center after being scanned by radiologists and ultrasonologists somewhere. The patients come to us with very worried about what to do, and that is where she helps us. Dr. Arindam Das, who is a fellow of fetal medicine, who was done from Chennai. Dr. Suresh has spent around 2.5 years with him, and he's an accomplished ultrasonologist, fetal medicine specialist. Very few people will actually know him because very shy, and he will never get up the dais to present anything. And I know him, know his father also. I've worked under his father, Dr. B.N. Das, at Ramakrishna Mission Seva Pratishthan, where he was the head of the department. And he's with us, and we're very happy, we are very honored. Dr. Anish Kumar Mondal, he comes from a very gynecologist family. Many of you probably know his father, Dr. Ananda Kumar Mondal, who is the son-in-law of Dr. Vishwanath Das. So he has a very good heritage of gynecology, and he has chosen to be in radiology, and he was working, anyway, we'll talk everything about him, and he's very happy that he's here. Dr. Girija Warrior, who is actually an obstetrician gynecologist. And deliberately she left Obs and Gynae. She left Obs and Gynae a long time back after her MD from SSKM. The first time I met her was when she was pregnant. She somehow heard my name, that was 20 years ago. And she came to me, "Amar ekটু ultrasound kore bolben, bachchata bhalo ache kina?" So that is when I met her first. So, and I was completely dethroned by her looks. She was exactly looking like, what should I say, Lakshmi or Saraswati or something like that. She was. Now, Khurshid Alam, where is Khurshid? She has joined recently as an academic coordinator, and any of you, if you don't know him, he has a vast knowledge in fetal medicine. I really relish when he takes classes, because he takes trainee classes over at IFM. I make a point to sit in his classes because every time I learn something new, not something, many things new. And the way, the approach of fetal medicine that he has is par excellent. Dr. Nitin Gupta, very close, what should I say? So he was sent by Dr. Ashok Khurana in Delhi. He just rang me up and said, "I have a very nice chap, very bright chap. Do you have a vacancy if you can give him a place?" And so I'm very honored to have Nitin over here. But fortunately for him, unfortunately for us, he has moved to Jaipur with his wife, Monica, and two lovely son and daughters. And they were integral part of IFM, still an integral part of IFM. So I said it is not possible to do anything of IFM without Nitin being around. Unfortunately, Monica couldn't come. And he's going to conduct a session of trainee session. Many of the trainees that he has trained are now big fetal medicine specialists all over the country. They have come just to be with us for a few minutes. And thank you, Nitin, for coming. Dr. Shashwati Mukhopadhyay, the clinical geneticist. Shashwati Mukhopadhyay, she's an Obs and Gynae. She has gone into genetics and now attached to Apollo. She's attached to us also. And we're very fortunate to have her. And we have all problems of genetics, and she has actually worked with Dr. Rtna Duapuri. And we are very fortunate to have her as a backup. Dr. Dipanjana Datta, who doesn't know her? Where is Dipanjana, the pretty face of IFM? So I'm very fortunate, Dipanjana, to have you around, and she makes things very lucid for patients. Emily, where is Emily Bandopadhyay? Please come over. She's another genetic counselor. They are all doctors in a way. They have done their PhD. So they're really doing great service. And no other than Dr. Daljit Kaur. I would like to introduce Dr. Daljit Kaur because it was not possible for me to manage so many people, faculty, one coming after the other, when they are on leave and when they are not leave, what machine they want, who has to type for whom, because they all have their preferences, who wants to use Viewpoint, who wants to use Sonocare, which machine, because we have 4 machines, so there is always a thing. So all these things, it's impossible for me to manage. How many patients one does and how many patients, when the patients are coming, the waiting time and the doctor's time, it is not possible for me, impossible for me. So it is not be possible without her. And of course, there are staff to manage, somebody having dysmenorrhea, somebody having parent-teacher meeting, and all those sort of things, and that's very important. Now we have a group, Dr. Upasana. Where is Dr. Upasana? Upasana Mukherjee, please come over. And Dr. Yashodhara. They are all genetic counselors who are still attached to IFM. They were attached to IFM at one point of time, full-time, and now they have moved on to different places. Dr. Deblina Kaur, one of our very important trainees. Dr. Vrunda, Dr. Neetu. Neetu has come from Ranchi, Vrunda has come from Delhi, Deblina has come, and who else? Am I missing somebody? Who has? Ashita has come from Patna. Ashita, please come from Patna. They are all our old trainees who have graduated and then moved on. And they have already made good names for them, and I feel proud when I meet them in SFM conferences, from Patna, from Ranchi, from Delhi, from everywhere. And then already people who are already working with us, Dr. Ankur, still a trainee, Dr. Shaheli Kapat, is she here? Yes, please come over. And you will soon be hearing their names also after maybe 1 or 2 years. And Dr. Debabrata, has you come? Dr. Amrit. Debabrata, please come. Amrit couldn't come. So He's not coming, okay. So that's the full team we have. Have I missed anybody? I don't know. I made a list. I told Ankur to make a list. Who else? Yes, please come. So this is our small team, and we try to serve the patients, we try to serve the fetus, and we try to serve you. So thank you, ladies and gentlemen, and please bless us so that I present before you the team IFM. So this is the team IFM. So I am only a small part. I just sit there and sort of try to I try to sort of grease and oil and shout and cool and calm, and they are the people who make me cool down. Acha, tick, 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 acha. If the Acha, I'm a worker, yes. I'm a worker, I'm being led by them. Thank you. Just take a one. Yeah, Shauli Ghosh. Where is Shauli? Please come over. Sorry. That's what I was saying. I'm missing somebody. Please, he's a genetic counselor. That's why I keep forgetting. Maybe I'm having Alzheimer. I don't know. ठीक है, so Kamal.
Kushada, you want to say something?
I'll just take 1 minute to present before you a person who has gone into a... I'll take just 1 minute with permission of Seetha to present before you a person whom I call a personality now. And he's no other than my colleague, my junior brother, a few years younger to me from the same college. But he has grown into a leader. I've seen him grown into a leader. Apart from his academic qualifications, he has all the academic qualifications necessary. He has all the surgical skills necessary. He was the president of IAG, the Gynecological Endoscopic Surgery. And I've seen him giving leadership for national conferences, both in international conferences, also in RCOG, International Conference in 2014, when he was very young. And he was the clinical secretary when I was the president. And now he was the organizing chairperson of the AICOG 2023, which is probably the best AICOG so far in the history of AICOG. And I present before you Dr. Bhaskar Pal, and he's an aspirant, he's a leader, and there's no other person fit enough to become the Foxy president, to lead our national body called Foxy, so that we represent it in FIGO and SAFOG and AOFOG and so on. So I would really, really be very happy if all of you support him and spread the word around so that he gets elected and leads the Foxy, the BOGS president, president from BOGS after many, many years. Bhaskar, would you like to request you to talk a few words? Thank you.
Thank you, Kushada, for the kind words. I'm not going to say anything about myself or my election. Tomorrow will be exactly, I'll complete 21 years that I came back to India and started my practice. And we came from a very structured atmosphere in UK with fetal medicine units in all our hospitals. And we came and we were aghast to find the quality of sonographies, people not having sonographies. And we discovered Kushada. I did not know Kushada from college. He was 5 or 6 years senior to me. So we just, he had just left for PGI when I joined college. And when we are young, we dabble in many things till we find our calling. And early in our days, Professor Sudip Chakraborty, who's not in here, and says, Kusha wears many hats, but give a ultrasound probe in his hand and he'll have a magical transformation. He found his calling, and he's been an inspiration to many of us. You want to like to be, he's liked by everybody, so you want to be like that. You want to be popular. He has always been a good student. He's been the poster boy of Medical College and the poster boy of PGI Chandigarh. And he's inspired, I think, at the present moment, I may be one generation after him. There are possibly 2 or 3 generations after him. Now, every month we find somebody who's done a fellowship in fetal medicine coming back to India. So, I think he's been the pioneer in fostering the cause of fetal medicine, and like everybody is so aware today that we need 2 proper scans at least, preferably 3, and then they need to be done by trained people. It is all due to him, and inspired generations of youngsters to take up fetal medicine. It is very difficult to leave doing cesarean sections or hysterectomies and go into something like that, which is much more time consuming. And I think hats off to you, Kushada, and I wish your center all the best. Thank you. Okay, Kolkata is hosting a fetal medicine, dedicated fetal medicine conference. When I wanted to bring this conference to Calcutta, this is a Foxy National Conference, and for the first time, Foxy and SFM are in collaboration. They are a little suspicious of each other, and I have great relations with the leaders of both the organizations, and they have agreed. And when I brought it to Kushada and Seetha, and I said, I give you one promise, I will not interfere in the scientific program, I will not speak, and nobody who's into fetal medicine will speak in that conference. We don't want it to be a political conference. We want it to be a pure academic conference. And I think it's going to be a great conference with 4 international faculty who are who's who in their fields, with a fetal interventions workshop. Fetal interventions, the sort which, some of which we still don't do in India, and also almost every eminent national faculties in their field, yes, including Dr. Rtna Duapuri. And while saying not only fetal medicine, I still remember in my early days I needed a patient who needed a serious genetic counseling, and I was told you have to send it to Dr. I.C. Varma's unit. Today we are spoiled for choice. I have at least 3 geneticists who've come and met me. If you have a patient, send. And then we had a guy who's to come to you and then went to SGPGI. And we are blessed now. Now we are complete in terms of fetal medicine services, and that's great for the patient, win-win situation for everyone. Thank you.
May I please invite, next we go on to have a few words from Kamal. Kamal Oswal, sir.
Good evening, everybody. Really, we are from Team IFM. We are honored and privileged to have you all here for this Ek Sham IFM ke naam. Thank you, everybody. And now, when we started doing ultrasound around 91 from Ramakrishna Mission. Then came Dr. Kushagradhi Ghosh, and he showed us how to do the fetal echo, and our whole outlook of doing ultrasound has changed after learning from him. And now the ultrasound has evolved in such a way that even the minor abnormality we can pick up. And one thing, the ultrasound has also opened up a lot of avenues. Now we can do prenatal diagnosis, we can do the genetic testing, we can do all the intervention also. So now the field is widely open, and anybody who is doing a obstetrics practice or doing a radiology practice, anything, you have to learn the ultrasound very well. And since the whole field has widened, so we have to also learn about the genetic also. So everything you have to learn. And so I think I am blessed to work with in IFM, with Dr. Kushagradhi Ghosh and the whole team. Thank you, everybody.
Thank you, Kamalda, for those words, encouraging words always. And for the end of the inauguration, may I please invite Dr. Daljit to deliver the vote of thanks. Thank you.
A very special thanks to Rtna ma'am, who made it today after a really tiring journey. Thank you so much, ma'am. And all the faculties who agreed to be with us today on this special event. Thank you so much. Basudeb sir, thank you so very much for the song as well as the sloka. A very emotional moment for IFM family. Dr. Ghosh, your family at IFM can't thank you enough for allowing us to be a part of your long-cherished dream. Seetha ma'am, lots and love to you. You know I'm not formal, so that's only love. Thank you, everyone who have been here with us since so many years, have been supporting IFM and have taken out time for IFM today on a Sunday. Thank you. Moving on, the great learning curve, what a name. I have named them as training buddies. Nitin sir, please step forward, accompanied by his special Amita di. Can I please request Dr. Arindam Das to felicitate him? Kahan gaya? Aap idhar ho. I don't think he needs an introduction. Still, I'm being formal. He's a radiologist with special interest in fetal medicine. He's the director of ASMI Fertility Clinic at Jaipur. Many congratulations and best wishes to you, sir.
Thank you, ma'am.
He's President-elect SFM Jaipur chapter. Now, Nitin sir will speak and introduce our team. इधर से आओ ये देरी करले হবে
Good evening, ladies and gentlemen, boys and girls. As sir has already told that it's an IFM family, and I take pride to say that in radiology fraternity, mostly people call me Kushadar Chele. So that's what they call me, that adopted son of Kushada, and I don't mind it. So thank you, Dr. Daljit, for kind words. I have noted down few points. I am not going to take much time. It is completely not an informal talk. So I have had the pleasure, rather honor, of working at IFM for little less than a decade. And in particular, working with, rather under guidance of Kusha sir, which whom my kids fondly call Kushada sir, because they usually keep on hearing from me and my wife, Kushada, so then they add sir also, then they call him Kushada sir. Kushada, one of the most positive, most generous person I have ever known. Kusha sir and Oswal sir, being two founding fathers, not only for the Institute of Fetal Medicine, but also of fetal medicine in this part of country. They have taught me a lot. They are like so elegant, so beautiful, just like a wow. So it's like when you work with them, you are not an employee, you are not a colleague, you are a family. Since Daljit asked me to share my experience at IFM, I would like to sum up in a very small line. At IFM is the place which made me what I am. Way back when I met sir, I was a naive fetal medicine guy, and I have reached to this level. It was all because of his blessings, his teaching, his guidance. The tips and tricks to handle the practical situation in fetal medicine, Probably none can teach you better than Kusha sir. Way back in 2014, I used to hear from my colleagues that there is a guy in the town who does CVS like drawing a blood sample. You blink and the sampling is done. So I wish that someday I will work with him, and God listened to me, as it is being said that जब किसी चीज को आप बहुत शिद्दत से चाहते हैं तो पूरी कायनात उसे मिलाने में लग जाती है. So probably that happened with me, and I am thankful to God for that. At IFM, we have learned, we have taught, we have worked to put our best for patients. As Kushada says many times, your reports should be concluding rather than confusing. We had honor of organizing many CMEs, courses, fellowships, hands-on workshops. Stalwarts like Professor Suresh, Dr. Edward Gretakos have conducted workshops at IFM, and most importantly, beyond academics, we had fun, we created memories over there. Last but not the least, I also thank all the colleagues who came as trainee and now are masters on their own, as at times they ask such a questions which make you think, which made you read and made you wise. I would extend my gratitude towards Dr. Deblina, Dr. Ashita, Dr. Nitu, Dr. Setu, Dr. Ankur, Dr. Saheli, and many more. Thank you, Kusa sir, Oswal sir, and Daljit madam for giving me this opportunity to share my experience. Before I conclude, I would quote Steve Jobs. He used to say, stay foolish, stay hungry. I would like to add one more word to that, which Kusha sir usually say, stay focused. When you put the needle, your needle should not be out of the ultrasound path. It should be under continuous ultrasound guidance. So stay hungry, stay foolish, but stay focused as well. Thank you. I would like to share a very casual video. We have already seen a small clip of IFM. This is what, last few years, how we spent at IFM. Can you please?
चला जाता हूँ किसी की धुन में धड़कते दिल के तराने लिए चला जाता हूँ किसी की धुन में धड़कते दिल के तराने लिए मिलन की मस्ती भरी आँखों में हजारों सपने सुहाने लिए हो चला जाता हूँ किसी की धुन में धड़कते दिल के तराने लिए ये मस्ती के नजारे हैं तो ऐसे में तमन्ना कैसा मेरी कसम जो लहराती डगरिया हो तो फिर क्यों ना चलूं मैं बहका बहका दे मेरे जीवन में ये शाम आई है मोहब्बत वाले जमाने लिए हो चला जाता हूँ किसी की धुन में धड़कते दिल के तराने लिए आलम भी अजब होगा वो जब मेरे करीब आएगी मेरी कसम कभी बैया छुड़ा लेगी कभी हंस के गले से लग हाय मेरी बाहों में मचल जाएगी वो सच्चे झूठे बहाने लिए हो चला जाता हूँ किसी की धुन में धड़कते दिल के तराने लिए बहारों में नजारों में.
Thank you very much. I always feel nostalgic whenever I go through these pictures and it makes us emotional, and thank you, sir, for considering me as an integral part of the IFM family. Thank you. I would like to invite Ashita, Dr. Ashita for next talk, and a big thanks to Dr. Arindam Das, who has always been a constant support at IFM to me. Whenever there are a number of scans, he is always there to share the responsibility with me. And for this particular video, special thanks to Dr. Daljit for providing me a few of the pictures, and Deblina, who helped me in preparing this PPT. Thank you. Ashita, please come and share your experience. I'd like to invite Yashodhara to felicitate Dr. Ashita. Please come.
Good evening, respected teacher. Coming to IFM is like coming back to home for me, and sir knows it very well. Okay. I will like to give my brief description when I came here. A consultant gynecologist having no knowledge of ultrasonography. And it is really scary for anyone to teach such person who is not knowing even the ABC of ultrasound. But finally I convinced somehow Dr. Kushagradhi Ghosh sir to allow me to learn ultrasonography in this institute. How to change? Excuse me. So, okay. So, I just want to show you my first ultrasound probe. It is day 1 of my training, and sir, it is a valuable possession for me. I still keep it in my ultrasound, in my study table every day. This is my first probe made by sir himself, and this is my khata, as sir usually calls it. With this probe on day 1, sir described all the essential movements, rotation, dipping, angulation, and I learned from this probe. Now, as a beginner, we all know, we start searching for patient every day, and the only criteria for a good patient for me at that time was lean and thin patients. And my Google search in this whole project was Nayandi and Geeta Di, Amita Din, Shriyanka. Thanks to all of them. In the evening, sir used to evaluate my all images, and you can see some images has been ticked correct and some has been crossed. And for my all bad images, I had a single excuse. Sir, baby was not in position. That is persistent unfavorable fetal position. Was the only excuse every time I used to give, sir. But very soon I learned my second one. That is poor penetration of sound wave. Thanks Dr. Arindam for giving me this. Day 1 with Dr. Arindam sir, there are 2 things. First, he scolded me for not knowing PPSW, that is poor penetration of sound wave. As I told him, I learned from him this. And second, he scolded me that how you don't know that it is apical 4-chamber and this is basal 4-chamber. Arindam sir, at that time even I don't know that heart can be seen from so many views, and amazed that why there is a need to look it into from so many views. Dr. Debashri Gangopadhyay ma'am, thank you for being my inspiration, my first teacher for cardiac evaluation, and it is who motivated me to apply some brain into the matters of the heart. Now coming to Dr. Daljit ma'am, it is thank you so much. It is now much more convenient to communicate with sir. Someone has said that which is more important, destination or journey? I will say companion. So thank you, Dr. Seetha ma'am, Arindam sir, Brinda, Neetu, Devlina, and Nitin sir especially for picking up my calls in this hectic schedule. So last, my teachers, in the last 7 days, I searched Google. I searched my all vocabularies to express my feeling for these two persons. But sorry, none of them could finally truly express my respect and gratitude for these two teachers. So just sir, I want to say thank you to both of you for teaching me, for guiding me as a teacher, as a guardian, for being there with me when I was broken and fragile, for being my 24/7 helpline number for the persons to whom I can share my all mistakes without having any fear of being judged or being criticized. Thank you, sir. Thank you so much. From me and from all of us whose life has been changed by the magical touch of IFM. Thank you, sir. Thank you, the entire team of Institute of Fetal Medicine, for giving us a learning opportunity so that we can serve and excel in our field. May Ma Saraswati bless all of us with knowledge and wisdom. Thank you so much.
Rashita. Now I would like to call Dr. Vrunda to share her experience at IFM. And I would also like to invite Dr. Saheli Kapat to felicitate Dr. Vrunda.
So I would like to say a few words of thank you. I will not take much of time. I had not prepared any PPT for that. I am Dr. Vrinda. I am presently working at Rainbow as a junior consultant in fetal medicine with Dr. Chanchal as my head. I am very honored for telling me to talk about my experience at IFM. I was just a DNB OBGY. When I came to Kolkata, I'm an army officer's wife, so I was moving around a lot. Every 3 years, I move around. So when I came to Calcutta, I was faced with COVID. We all faced COVID in 2020. Then in 2021, my friend Dr. Devlina told me that I can do a fetal medicine fellowship with Sir. So I joined fetal medicine in April 2021, and I was with Sir till September 2021. Those 6 months were my golden months. It was just a start to me, a new start for a new educational trip I went on. I'm extremely grateful for the opportunity and my heartfelt gratitude to Sir. He's really my guiding light for this journey into new eras of fetal medicine and genetics, and for the confidence he has instilled in me. I would also like to thank Dr. Kamal Oswal sir for co-mentoring me. I used to wait for those Fridays every week when he used to come in with his hard drive, which I call it as an image bank. He used to show me all his collections of the years and used to tell me to make a diagnosis seeing his images and clips. And he taught me the knobology, the fear I had with that machine. Those knobs are now a friend to me. And seeing sir working day in and almost day and night to make this team, it was very I was very honored for being with this team. My love to all IFM team. I had also has opportunity to have working with Dr. Seetha ma'am and Dr. Arindam sir, and last but not the least, Dr. Nitin sir, who was always there behind me, and he's the person who placed me with Dr. Chanchal in Delhi. So, and always coming to Kolkata would now be very an emotional trip to me, because I have started my new journey here. Thank you, sir.
Thank you, Dr. Brunda. Now I would like to invite Dr. Neetu. Please come, and Miss Savli Ghosh to felicitate her.
A very good evening to everyone. It's my proud privilege to be a part of IFM family. I have been practicing general radiology for quite a long time, and being a female radiologist, I get most of the fetal and breast imaging patients. So I decided to learn advanced fetal ultrasound and excel in my field to serve my patient in better way. Then I got to know about Dr. Kushagradhi Ghosh sir, who is a well-known expert in fetal medicine. When I came here, I found the environment was very cordial and nurturing, which sir and his team has created. It allowed me to learn and get confidence in fetal medicine. Dr. Kushagradhi Ghosh sir, Dr. Kamal Oswal sir, and Dr. Debasri ma'am taught fetal echo, which I have little knowledge. Dr. Seetha ma'am, Dr. Nitin sir, and Dr. Aringham sir taught me fetal imaging in detail. They were so humble and polite and always ready to teach. Their constructive feedback and guidance were instrumental in shaping my capabilities. I was practicing ultrasound-guided FNAC and procedures, but to be very, very honest, when I came to here and Dr. Ghosh sir taught me how to exactly introduce the needle, and it took away my fear while performing invasive procedures. I have been fortunate to witness advanced invasive procedures like intrauterine transfusion, selective fetal reduction by radiofrequency ablation, and laser. In my tenure, I am profoundly grateful to Dr. Kushagradhi Ghosh sir for being an exemplary teacher, mentor, and guide in the field of fetal medicine. This impact on my knowledge and skill will resonate throughout my career. Thank you for this platform. It is a beginning for me and want to keep learning throughout. Lastly, I want to thank everybody attached to this IFM family, and especially Dr. Daljit ma'am. I have learned something from each one of you. Thank you, sir and ma'am, from the core of my heart. Thank you.
Thank you, Dr. Neetu. Now I would like to call our the last fellow to share her experience, Dr. Deblina. Please come. And I would also like to invite Dr. Ankur to felicitate Deblina.
A very good evening. I'm Dr. Daljit Kaur, and I had joined the Institute of Fetal Medicine, Kolkata, as a trainee in the September of 2021. I had officially completed 6 months of training by March 2022, but I refused to budge for the next 1.5 years, and those were the most formative and productive years of my life. Of all the self-help books I have read, 2 advices have always stood out to me. Firstly, if you cannot see where you are going, ask someone who have already been there before. Apart from an individual's capability, resilience, exposure, and luck, I believe mentor is the single most important thing that can determine your path to success. A mentor allows to see the light inside you. I can only thank my stars for the mentor I have had, and I take this opportunity to thank Dr. Kushagradhi Ghosh sir, Dr. Kamal Oswal sir, Dr. Seetha ma'am. I'm not articulate enough to describe how incredibly lucky I am and indebted to all of you. From a novice who could barely touch a probe before joining IFM, you have groomed me to who I am today. Dr. Nitin Gupta sir, you have always been that push, "Arey kar legi tu," when the voice in my head had self-doubt. He had been our go-to person since day one for all the queries and problems. Dr. Monica have taught me the scanning in gynecology and fertility. You are as much a friend to me as a guide. Arindam da always had taught us quick tricks and trades and what elaborate counseling and documentation looks like. You have made learning fun by using your impeccable sense of humor every time. And of course, Daljit ma'am, who is our one-stop solution to any life problem. I'll just share a story. Once I got reprimanded at the traffic signal for failing the traffic light, and my driving license got confiscated. And in that moment of panic, only person I could think of is Daljit ma'am. And she actually got me out of that soup. Thank you, ma'am. And lastly, Ashita ma'am, Dipanjana madam, Khurshid sir, Devashri ma'am, you all have been inspiration to me, and I'm forever grateful to all of you for laying the foundation of my knowledge in fetal medicine. The second advice I have always believed in is that you're average of the 5 people you spend most of your time with. And in fact, 5 people around you will determine your success. And I'm blessed to have such a high-performing peer group around me. I thank Dr. Brunda, Dr. Nitu, Dr. Ankur, who have been my support system for quite some times now. They're all doing fantastic in their own sphere of life. And the IFM journey has been fun, fascinating, as well as a blessing to me. Thank you all, my dear mentors and friends. Thank you, sir.
Thank you all my training buddies and best wishes to all. Okay. I would take this opportunity to introduce Dr. Anish Kumar Mondol. I have something to say about him. He is fondly called by Girija ma'am as Star Anish. He is son of Dr. Anand Kumar Mondol and grandson of Dr. Bishwanath Das. Dr. Anish is presently working at IFM. He was working at Malda for a couple of years. He is a young, dynamic, and sincere radiologist with special interest in fetal medicine. Ever since he has joined, I have not heard a no from him. Presenting to you, Dr. Anish Mondol.
Thank you, Daljit ma'am, for such kind words. Good evening, my respected dignitaries, seniors and fellow colleagues. A warm welcome to everyone on our annual Foundation Day program here at ITC Royal Bengal. I am Dr. Anish Kumar Mondol, consultant radiologist and fetal medicine specialist here at IFM. I did my MBBS from Medical College, Kolkata, and thereafter underwent a training in postgraduate MD training in radiology from SSKM Hospital. As I was working for a couple of years in Malda, coming from a family of obstetricians, I already had a special interest in fetal imaging. So to pursue my interests, I contacted Dr. Kushagradhi Ghosh sir as everyone knows, he's a legend in this field. And he encouraged me to join his institute. And after that, everything fell into place like a jigsaw puzzle. Since I have started working here, I have loved it here. Interacting with our trainees and our senior colleagues. This makes this an ideal place to hone our skills and to upgrade ourselves. Thank you. Enjoy the evening.
Keeping the ball rolling, we move on to our next session. I would request Joyita to accompany Dr. Pranab Das Gupta sir, Dr. Kushagradhi Ghosh sir, Dr. B.N. Mullik sir, and Dr. Torun Kumar Roy sir to chair the session. I would request Dr. Khurshid Alam, an esteemed member and academic coordinator at IFM, to please felicitate Dr. Pranab Das Gupta sir. Khurshid sir, khane. Dr. Upasana Mukherjee to felicitate Dr. K.D. Ghosh sir. Sir, nahi? Sir, kothay? Sir, ekhane, Dr. B.N. Mullik sir. Dr. Nitin Gupta, sir ji, please. इसीलिए तो Dr. Anish Mondal to please felicitate Dr. T.K. Roy sir. Thank you. Now I would request Dr. Pranab Das Gupta sir to take the podium and keep the session going.
Good evening, ladies and gentlemen. After what I would call a most wonderful lecture by Dr. Puri, we now move to the second session after a wonderful inauguration. But before I invite the speaker, I would like to congratulate my friend Dr. Ghosh and what he called his small team of 26 people, and he called them a small team, 26 musketeers, for doing such a great job for Calcutta. Having said that, I'm 80 years. With great difficulty, I got only 4 assistants. The rest left me. So I would call Ghosh as Virat Kohli of the doctors for keeping 26 guys working under him for more than 10 years or more. Congratulations. Having said that, could I now invite the next speaker who will be talking on a very, very important subject, outcome after prenatal diagnosis of congenital cardiac disease. Dr. Debashree Gangopadhyay, MD FNB. Fellowship she got in pediatrics cardiology, Westmead Hospital and Sydney Hospital in Australia. Currently she is working as a senior consultant intervention pediatric cardiologist. Her achievements were multiple publications in national and international journals. Her special interests are in fetal cardiology. I have great pleasure to invite Dr. Debashree Gangopadhyay, please.
হ্যাঁ না না আমি দিয়ে দেবো আমি দিয়ে দেবো না না ঠিক আছে আমি ব্যারাকপুরে পৌঁছে দিতাম না আমি ব্যারাকপুরে পৌঁছে দিতাম ঠিক আছে
A very good evening to all the distinguished guests here, and thank you, sir, for the kind introduction. I'm really grateful to Kushada for giving me this opportunity to have a talk on this topic, which is outcome of common congenital cardiac defects and what happens after diagnosis. So I understand that now that we have begun with our dinner, I'll have to keep it to a very minimum, and I'll try to keep it very interesting also. So my declaration before I begin, that my job involves handling babies on both sides of the womb. So I see them before birth and also after birth. These are the few well-known facts about congenital heart disease, and I just want to highlight one point, that we have to remember that the incidence of heart disease is not only limited to the known high-risk population. So it's very essential to screen the whole population, irrespective of the risk status or the well-defined risks for heart disease. 50 to 60% of all the heart defects will need surgery or intervention, and 25% of them is critical, and those babies will need intervention in the newborn period. And we all know, and it has been multiple times published in many different journals, that early fetal diagnosis improves mortality and morbidity. And this is a very nice article which came out in Annals of Pediatric Cardiology in 2019, and they have listed the list of conditions where early diagnosis really improves the postnatal outcome. Now we know that if we focus on the four-chambered heart, we get to diagnose only 65% of the heart defects. And the three-vessel and three-VT view, if they are included in the screening, then we will be able to identify up to 90 to 95% of the defects. When I was preparing for the talk, I looked at how the practice differs between us in our country and in the resource-abundant setting. So I did not see much difference, and here is a list of common heart disease which leads to termination of pregnancy both in our country as well as in the resource-abundant setting. This is yet another study worth looking at. It is published from Czech Republic, where they have a very liberal interruption law, and the authors concluded that the parents' decision to continue with pregnancy was really in case of heart diseases with a favorable outcome. It was more influenced by the associated extracardiac abnormalities and genetic abnormalities. The same conclusion was drawn by the US group, where they have screened 3.3 million fetuses. And again, they concluded that first trimester diagnosis led to higher amount of termination of pregnancy in complex congenital heart diseases, and termination of pregnancy significantly decreased for anomalies with favorable outcome. This point is very important to note and take home maybe with us. So now I'd leave the statistics part and go to the interesting bit. I'd share a few case scenarios just to illustrate how the children do once they receive the diagnosis of congenital heart disease, maybe antenatally, and sometimes not all of them are fortunate enough to have the diagnosis before birth. Some of them I met also after birth. So this little guy was born in a family from North Dinajpur. Antenatal scans were all normal. And remember, this boy is now about 12 years old, so this history dates back to 12 years. The pediatrician, when checked the baby at around 3 weeks, he suspected some heart problem. And he came to us and he was diagnosed to have coarctation of aorta around 1 month of life. He underwent balloon coarctoplasty at our center in 2001, 2012, I think, 2012. He remained well till 2020, with hypertension being the only concern, as it is a common association with coarctation. Repeat CT scan at 10 years of age suggested recoarctation. So here what we did was stenting of the coarctation. And now, here you see the young man, 12-year-old, with a confident smile, happy to take on the world. This is another story. Look at this little beautiful baby who was born with a fetal diagnosis of coarctation of aorta about 2 years ago. The coarctation was really severe, so he needed surgical coarctoplasty in the newborn period, and again, at 1 year of age, he needed balloon coarctoplasty, balloon angioplasty of coarctation of aorta. Now, if you pay close attention to this video, can I have the sound, please? All right. So it's any other happy toddler, happy and exploring the whole world around him. It's a great story. This is yet another baby who was seen by me in 2016-17 at Rtna Duapuri. Had received a diagnosis of antenatal diagnosis of tetralogy of Fallot at 20 weeks of gestation. He was operated at 1 year of age, and there is no stopping him since. And sound. Papaya. Please keep the sounds up. Papaya. So this is the 1-year-old child. He is happy to learn and take everything from the mother that the mother has to offer. Now this is a little different story. This baby girl landed in our emergency at 4 months of age, crash landed rather, with a saturation of 40%. And we really had to work hard on her. And we operated on her. She was diagnosed with tetralogy of Fallot, did not have any antenatal diagnosis. And we managed her cyanotic spell and managed to operate her around 1 year of age. And now she's a bright toddler. She just stayed in Tamil Nadu for 3 months, and she was able to recite a poem in Tamilian language. She is such an intelligent girl. So TAPVC is again a common diagnosis, but not all TAPVCs need newborn surgery. This girl who now goes to class 10 was operated around age of 4 years for supracardiac TAPVC and has been well since. And for those who wonder what we do with the single ventricle physiology, this is the child who now goes to class 5 and the best boy in his class, and mom says he is a voracious eater as well. This is after 2 surgeries, one done around 6 months and one done around 5 years. And this is really a great outcome. Now many times we get isolated aortic stenosis in newborn, and the crux is to exclude hypoplastic left heart disease in a newborn. So this baby underwent successful balloon angioplasty of the aortic valve, and this is the gradual evolution of the baby from newborn to toddler to a very young and confident school-age boy.
Eyes दिखा, eyes दिखा, eyes. Teeth दिखा दो, teeth. Tongue दिखा दो.
So who said pulmonary atresia can't be tackled if we don't have an antenatal diagnosis? This baby is now nearly 2 years and underwent ductal stenting at 1 month of age and successful total repair around 1 year, and is now like any other normal baby. No one can say that she underwent 2 major procedures within first year of life. This is another story, very interesting one. This baby is now around 6 months old, one of twins. The other twin was normal. So, and this baby was diagnosed to have large VSD, and also there was suspicion that there could be many more. So naturally, the parents received the offer of termination of pregnancy, but this lady said to me that while she was traveling in a car, she heard about the story of Bipasha Basu, and that's what encouraged her to continue with her pregnancy. And I think we are fortunate enough that we have proved her decision correct. So this is the baby on the right-hand side after successful repair of all the defects that she had in the heart. So I'll just conclude by saying, universal cardiac screening of all fetuses at the time of anomaly scan is a must, and extracardiac and genetic association should be actively sought, because having another problem outside of heart and having a genetic problem to accompany it just doubles the risk of having a more sicker baby. In today's time, all CHDs are treatable and most of them are curable. Counseling on the heart disease management is best done by a cardiologist, and timely referral and counseling can save unwarranted loss of pregnancy. With that, I will leave you to enjoy this video. Watch the little one. He had received a diagnosis of tetralogy of Fallot around 20 weeks of gestation, and parents were counseled for termination of pregnancy. But they were wiser. So here we have the result. Storming the stage. And I'm ready to take on questions if there are any. Huh? Question nahi?
Most ultrasonography is done or echocardiography is done in Calcutta at 23 weeks. But through the literature I went, most of the centers abroad, good centers, do it between 16 to 20 weeks. Can you answer this, please?
Yeah, absolutely, sir. That's a very good point you highlighted. The emphasis is now shifting from second trimester to early second trimester or late first trimester, especially in kids who have higher translucency thickness. So the cutoff, they say it's 3.5 millimeters, and if the NT thickness is at 3.5 or more than that, it can be an association, it could be a pointer towards trisomy 21, and in absence of that also, the association of cardiac disease with knuckle translucency thickness is a well-established marker now. And if there is one such suspicion, then these babies need to have earlier scan. And no doubt, if you are able to diagnose major heart defects, by major I mean univentricular hearts, and only probably that, and heart defects with extracardiac problems, we also have ample time to probe into the genetics of that fetus. So we have the the wholesome picture. So we can sit down with the family and give them the correct prognosis.
Thank you very much.
Thank you, sir.
Now it's open to questions.
Yes, ma'am. Any medico-legal Hello? Hello?
Yes, sir. Yes, please.
Hello? Medico-legal relation, if we do not do the first trimester or early second trimester training, suppose once one doctor forget to do it and then the patient receives the abnormal baby, is there any medico-legal relation?
Sir, what I would say is, see, this is a different perspective. Like, I have had a friend who had a very unfortunate incident happening to her. So, there was a missed ventricular septal defect. And for that, even though it's a curable disease, totally curable disease, and so one-time surgery and a lifetime cure, no other complications, still, this case went to court because she missed it. So at this era, because the litigation and medico-legal problems have gone up so far, so high, I think we should be cautious and try and, give our advice as per the guidelines. That would be the best practice to keep ourselves safe. And then if the patients do not follow, then at least you are safe in the court of law. And you can say, I had advised, but then my advice was not followed. But of course, this has got a clinical implication as well. If you advise it earlier on, you get more time to sit down, to think over, to counsel, maybe take a second opinion.
Thank you.
Thank you, sir.
Dr. Ghosh, could I ask a question to Mrs. Puri? Dr. Puri? Dr. Puri?
Thank you so much, Devashri ma'am. As usual, coffee, due. Thank you, dignitaries in the chair. Now we would move on to our theme of today's scientific program. You ask, we answer. May I please request Papia to please accompany Dr. Rohit Gutgutia, sir. Dr. Kanchan Mukherjee, sir. And Dr. Seetha Ramamurthy Pal. Deblina ma'am. বলে দিচ্ছি আমি যাচ্ছি Devlina ma'am, please felicitate Dr. Rohit Gutgutia, sir. Girija ma'am, Dr. Kanchan Mukherjee, sir, and Seetha madam. दो बारी, दूसरी बारी, बार-बार प्यार मैम. बोलना तो रोहित
Can I have a quick place? Ghosh, well done.
Experts would take over the session with Dr. Rtna ma'am. Rtna ma'am.
Madam. We won't be able to see the slides. Yeah.
Yeah.
Let us.
It's just 40 years.
I know. Korto, amar pa muchke geche. I sprained my foot.
Thank you.
Thank you everybody for waiting, whoever is. And so we're going to have a short session on some case scenarios that we see on a regular basis and how we go about it. So we have 3 cases for you, and we have our expert, Madam Dr. Rtna Duapuri, as to what would be the right way of approaching this and what are the practical problems that we face in going about doing the test. So the first case will be by Dr. Rohit Gutgutia, and I'll hand over the mic to him.
Yeah. So, ma'am, this is a pretty common scenario in our practice. We do regular fertility practice.
May I please sorry to interrupt. Can I request for some silence in the hall, please, so that we can concentrate on the cases? Thank you.
So very often these couples come with what we call recurrent pregnancy losses. So this couple was married for 7 years, 29, 28. 4, all of them were natural conceptions. The first one was a UPT positive but biochemical. The second was pregnancy of unknown location. The third was detected to be a pregnancy, intrauterine blighted or unembryonic pregnancy. And the last one, we had a heartbeat, but we lost it. So standard hysteroscopy, APLA, and all that were carried out. DNA frag was done for the male partner, 15%, so that's considered normal. And then we did the AMH, which was slightly on the lower side for the female, considering she was 28 years old. Now we are to put her for a genetic testing. So the standard question that we get to be confused about is about, like, do we do a G-banded karyotype, or what is known as a high-resolution karyotype, or as you said today, a CMA? How do we do it?
Yeah. So I think it's important to understand that there are different resolutions of looking at chromosomes. So the basic resolution is a 550 band karyotype, and that is what is required for routine clinical practice, like in this clinical scenario.
Could you have some silence at the back, please? Please. Session is still on.
No, that's fine. I think we'll have to speak louder to drown that noise. Yeah. Okay. So we do the basic karyotype, which is the 550 band karyotype in this clinical scenario, because 3 to 5% can have a balanced translocation. Because they are physically fine, that is why we want to look at any abnormality that is balanced. A chromosomal microarray only looks at imbalances. So a chromosomal microarray is never ever performed on normal individuals. And the third thing that you asked was the high resolution karyotype. That is not required as a routine. Sometimes if, say, in a product of conception, we've done a microarray and we found something that is very specific, what we call a double segment imbalance. That means in one chromosome there's a deletion, in one chromosome there's a duplication. And I want to make sure that we've not missed anything. Only then do we do a high resolution karyotype, but not in a routine practice. Here you just do a 550 band karyotype.
And do you see any reason or scope for doing a clinical exome sequencing or a whole exome sequencing?
Not at all. Not at all. That is in the research area. Even if you find a variant, it's not going to help you. So no exome sequencing for recurrent pregnancy loss.
Thank you.
Either for the parents or for the product of conception.
Madam, I had a question that if you, in cases of these recurrent pregnancy losses, if you have to send, if you do get on the third miscarriage loss, if you do get the products of conception, what would be the ideal test to do in that, and how would you send it? Yeah.
So we don't do a karyotype anymore in the product of conception because the diagnostic yield is 50% because it requires dividing cells and you may not get it there. So we can do one of two tests. One is a chromosomal microarray. We don't need to do a high resolution microarray. In my hospital, I do the low resolution, even less than 750K. And because, you know what we observe, most of them are abnormalities of number. If they are structural abnormalities, they are at the ends of chromosomes, what we call subterminal, subtelomeric. So the other test, which can also be used depending upon the lab where you send it, is the subtelomeric MLPA. So these two options are there.
So all labs don't do the subtelomeric?
No.
So which
No.
ones would you ask for specifically in, if we want?
So it's fine if the cost is okay. MLPA is cheaper than CMA. CMA is an expensive test. The technology is expensive.
Right.
So I have both in my lab. It's just that, as a routine, the CMA goes, the low density CMA, but if we have cost issues, I do a subtelomeric MLPA. I'm not worried about missing anything.
Right, okay.
But it's important. One thing I want to say.
Yes, ma'am.
The low density chromosomal microarray will miss triploidy. But remember, when you're doing a POC, you're doing maternal cell contamination and it will be picked up in that.
So the message is that if you are doing any recurrent pregnancy loss investigations, please don't just do a karyotype. You have to go ahead with a chromosomal microarray with a maternal cell contamination always whenever we do a molecular test. Thank
So
you.
ma'am, what's your opinion regarding SMA panels in these sort of cases?
This has nothing to do with SMA. SMA, we were just talking, I was talking to a friend of mine here. We've identified through 4 studies in India that the carrier frequency is as high as for beta thalassemia. We've brought out new carrier screening recommendations by the Society for Indian Academy of Medical Genetics that are endorsed by Foxy and SFM. We just released it in December. It'll be up on the website soon, where universal carrier screening is recommended for beta thalassemia and spinal muscular atrophy. Just for that for SMA, we have to do MLPA. It's, there's no Sanger sequencing or NGS.
Yes.
Okay, we do MLPA. So SMA and no correlation. You could do SMA as a routine universal carrier screening. SMA is a neuromuscular disorder and it can present with fetal akinesia. It can present with, polyhydramnios, or usually at birth, respiratory distress and hypotonia.
So nothing to do with recurrent pregnancy loss?
Not at all. Not at all.
And if I'm not mistaken, the frequency is almost 1 in 50 of SMA.
Yes, 1 in 50.
So
The
it's
carrier
quite
frequency,
high.
it
Yeah.
is.
So, okay. If there are no other questions from the audience who's listening, we'll go on to the next case.
Just as a follow-up on this, we were to recommend a PGT for her, for the couple for the next attempt. And would we instruct the lab specifically for other than the aneuploidy to look for something else other than the aneuploidy? Is aneuploidy is good enough?
If one of the partners is a translocation carrier, then you have to do a PGT SR, not a A.
So we move on to the second case, which is a very common scenario. A 26-year-old primigravida who's had an IVF conception for male subfertility, and she came in for a 12 weeks combined first trimester scan, where the scan was essentially normal, and the combined FTS risk was quoted as 1 in 50, with a PAP-A of 0.1 moms. So, just to broach the topic, will anybody would like to say anything you would want to know, or depending on this report, because this is an IVF pregnancy, and I'll just say that you need to make sure that the donor age is put in rather than the mother's age, though her age is low here, but being an IVF conception is important to note that. So I'll go on to the case further. Next slide, please. So her obstetrician went ahead and got a NIPT test done here. Now it is debatable as to how many would recommend an NIPT of a risk of 1 in 50, but the NIPT was done in whatever interest, because it's an IVF pregnancy, maybe she didn't want to go ahead with anything else, and that came back as high risk for trisomy 21. So, madam, I just wanted to know your opinion as to, ideally, would it have been the right way? And what should be done further if the NIPT, and the fallacies of doing NIPT and,
Okay. So, once the NIPT is a screen positive, it has to be confirmed by the invasive test. Because remember, this is a screening test. so it's not diagnostic. You can have a situation where the NIPT is screen positive and your diagnostic test is normal. So before you even order an NIPT, all this counseling should be done because it's an IVF conception. Secondly, in an IVF, we have to be careful, see the first ultrasound carefully, because if there's a vanishing twin, that can cause a false positive. So I think these are the two things that are very important as far as an IVF and an NIPT goes. And the third thing which I have to say is that, I mean, it's fair if they had a screen of 1 in 50, the family opted, well, maybe it can be negative, so they did an NIPT. But we just have to ensure the gestation and we have enough time to confirm, because sometimes people go and discontinue based on a screen positive NIPT, which is incorrect.
May I just ask another question? Suppose this was screen negative on NIPT, but the fetal fraction is 3% here. How much importance would you attach to that?
Okay. So the story started, I think 2012 was when NIPT came in. Yeah. And at that time, we used to speak with, Perkin Elmer has a geneticist who's a very good friend in the US. And she would always tell us that 8% is the cutoff. If it's 8%, we are confident in giving a screen cutoff. If it's less than that, then we are not. But over the years, the algorithms have improved. So that's fair. As long as the lab is comfortable, that means their algorithms are comfortable, they've done their screening. So we will have to believe it at that, but at the same time believe that it's a screening test. The sensitivity is 98 to 99%. I have seen 3 children with Down syndrome after a screen negative NIPT. It will happen because it's a screening test. And I think it's important to guide the families about that. That's all.
So at this point of time, what would you say the correct fetal fraction should be for us? Because we do recommend 4%. It's come down
but
to
it's come down to about 3%.
So 3%
I've not seen any lab reported less than 3%.
Right. But it's important to know the fetal fraction.
Yes, it is.
Whenever we see the report.
I don't think now there are any labs who don't report a fetal fraction.
Yeah, true. And the other important message you said, that is always with NIPT coming as high risk, you have to confirm it with invasive testing and not terminate just based on the NIPT positive report. But interestingly, you said that you have seen cases when NIPT was negative and there was Down syndrome.
It's a screening test. It's a screening test.
Just a small question, ma'am. Suppose this was the triplets or twin pregnancy, and you do the amniocentesis and you find. Then suppose all the 3 are girls, they keep changing positions. So how will you know which particular baby is positive for a particular syndrome?
So firstly, if they are triplets, no screening test works.
No, okay.
So we can't do either a first trimester biochemical or an NIPT. We have to rely on the ultrasound. If they are twins, the NIPT screen positive cannot tell us which twin is affected, and you have to test both the twins. And the fetal medicine people will tell you how they label the twins. Yeah. They draw a diagram and label. And I think you're better than I am there.
Basically, it is preferred that the same person does scanning and rest of the procedure as well. So they have this mental figuring out. Then we mention which one is lower, which one is left, which one is right, which placenta is that.
They change positions.
So
but I had a patient, I made a wrong diagnosis.
That is actually counseled beforehand, that it can be a wrong identification.
Could you label a baby?
Yes. We call it mapping, twins mapping or triplet mapping, but really we cannot until and unless there is a particular feature, like one has a single umbilical artery, the other one has a echogenic focus. So we mention that. So we try our best, but it is not accurate, cannot be accurate.
Another thing I would, since the topic of multiple pregnancy has come up, what would you say, how does NIPT perform in multiple pregnancies, depending on the chorionicity, of course, but generally how?
Yeah. So if you have monochorionic, it's like a singleton. If you have a dichorionic for Down syndrome, now it is well established that the screening performance is as per singleton. For 13 and 18, I don't think we are so worried because you guys are great at ultrasounds. And there's not enough of data for 13 and 18 because the incidence of those disorders is so limited that even the most recent papers say that though they say that the sensitivity is 98 to 99% for 18 and 13 respectively, the data is too limited for twins. But we usually take it as per singleton.
Right. And in cases, since you mentioned about vanishing twin, if there is a vanishing twin earlier, we really will not be able to do the biochemical screening because we'll get a skewed result. But according to you, what would be the ideal time to wait until we get that one done, or should we just rely on the ultrasound?
It's interesting. There is a very, very recent paper in prenatal diagnosis where they have addressed this issue of the vanishing twin, and do we have a good time to say, well, after 4 weeks, after 8 weeks, you can do it. The data is skewed. The line says that it's not a good idea to do a screening test. However, you may wait till 8 weeks to do it. The thing with vanishing twins is the false positive rate is higher, but the false negative rate remains the same. But always remember, the false negative rate is not reported in literature. Nobody likes to report it. And NIPT is a commercially driven test. So I think as academics people and as clinicians and doctors, we have to keep all this in mind. It's a great test. I mean, I love the test. But we have to understand the limitations and therefore not give false hopes to the families. That's all.
Thank you, madam. And since you brought the point of limitations, I just wanted, coming from you, that NIPT is validated for which syndromes, or because it's so commercially hyped and we think that it is the panacea now.
We really think it's the god of all things. It's not.
So we want to come.
Yeah, it's 21. It's like first trimester screen, the biochemical screen was for 21, and 13, 18 piggybacked along it. So is NIPT. It's great for 21. It's okay for 13 and 18. It's not good for sex chromosome abnormalities, and it's creating a lot of havoc because out of all the sex chromosomal abnormalities, there's no problem with Klinefelter, XXX, or XYY. These are abnormalities where postnatally most of them are intellectually normal. It's Turner syndrome. 99% of the Turner syndrome miscarry. It is the 1% which is born, and that 1% does not have intellectual disability. They have infertility. They have primary amenorrhea, and we have hundreds of other causes for all this. So it's actually a double-edged sword screening for sex chromosome abnormalities. Sometimes the lady herself is a mosaic carrier, and when we are doing all this testing, that comes up. So it brings up many ethical issues, and it is not validated for copy number variations, though the latest guidelines say 22q11, but I don't think it's great to do it, and not at all for the rare autosomal trisomy. So I think we are good in just limiting it to the common aneuploidies.
Yeah. Thank you.
Ma'am, the accuracy and sensitivity in IVF donor and self, is it same for NIPS?
Yeah. As long as when we are doing it, we must note that there is a donor. So actually in the kind of technology that is used now, it doesn't really differentiate a donor from the mother, but we can get different peaks because of, it's not using SNPs, it's just counting. But in the SNPs, you would get a different readout, but none of the companies are doing SNP-based in India anymore.
Okay.
Seetha, before you go to the next case, can I ask her, I have to go back for a personal work, ask her a question on her talk, if you don't mind.
Sure.
Yeah. Doctor, I'm going out of context before the next case. Just an observation in your talk. You made a very solid comment that if you do the first trimester screening and it's negative, there's no need to do the second trimester. I would like to answer that in such a way. I've been practicing for 45 years. I've always done both the tests because I've found many times the first trimester is negative, the other one is positive. Or the first trimester is positive, the other one is negative. Particularly in patients who are above 35 years with bad obstetric history. your comments on that. If you tell me no, then I'll stop doing it from tomorrow. I'll only do one test. I promise you.
To answer your question, but I'd want to know in what percentage did the invasive test actually confirm that the child had Down syndrome?
About 5%.
Where the first trimester was negative?
Negative.
So the sensitivity of the first trimester test is 85%. The sensitivity of the quadruple is also 85%. Very often we find that the first trimester is, and when we are doing the test, we have to tell the patient that that is all we can screen for. You know, it's not as if we can pick up all, because we would be doing many invasive procedures that are not required to identify that one child with Down syndrome. So this is universally accepted. So either we do a contingent model where if the screen is greater than 1 in 50, do the invasive. 1 in 50 to 1 in 500, 600, you do either NIPT, or you do the quadruple using the a priori risk of that of the first trimester.
Okay.
But not as a standalone
Okay.
test.
But then I thought quadruple marker also roots out neurological problems.
Yes, that's what I was coming to.
So I think we should do both, in my opinion. What do you think of that? No,
Then we should. No, you just do the AFP alone. You do the AFP alone. It's a great test because targeted is always better. If I know that everybody there, we have great fetal medicine and ultrasound people, but it's still the human eye. And targeted is better. So if you've done a first trimester screen, you could do an AFP value, put it into a mom, and then see the risk.
my patients I can now take more money and charge them for the second trimester.
Thank you.
Thank you, sir. One of the senior doctors, very dear friend of mine, doing a good job. This young lady I know for many years. So I have to go back for a case. It was a pleasure knowing you.
Thank you, sir.
Very, very well.
Thank you, sir. Thank you.
Thank you, Pranavda. Thank you. So this lady obviously had an invasive testing. And next slide, please. Hello, excuse me. Next slide, please. Yeah. And it confirmed trisomy 21 and the pregnancy was terminated. We'll move on to the next case and Kanchan will take that up.
Thank you, Seetha. So next slide, please.
Yeah, this confirmed. So as Madam was just saying that we did a FISH, but it had to be confirmed by a full karyotype to know the exact type of trisomy 21 so that we can assess the recurrence risk in the next pregnancy. I'll leave it at that and leave it to Kanchan. Yes.
Mine is an ongoing case. Madam, it's very interesting in the sense...
Next slide, please.
this is an ongoing case. She is now about 20 weeks pregnant, into her second pregnancy, having had one miscarriage before. 35-year-old, wife is HBE trait and husband beta trait. First one was a spontaneous miscarriage. Second one is E-beta thalassemia, and the child is on regular transfusion. It's only about 4 years old now. In the current pregnancy, she has a pair of twins, which is monochorionic diamniotic.
Spontaneous.
So, spontaneous conception. And we did a CVS for thalassemia, and fetus is normal, as if it is readable at all, the top slide there, top image. And then whatever was left with that sample, we have done a QF-PCR, and that was also normal. So everything hunky-dory at 12 weeks. Now at this point, what I would like you to comment, please, is we sampled only one placenta. Do you have any comment on that?
This works most of the times.
Right.
There is a small percentage which can be dichorionic, okay? But that's fine. We just sample one.
Right. Thank you so much. So we did not expect any further problems. Next slide, please. Next slide. But as she appears for her anatomy scan at 23 weeks, there was now signs for TTTS, but twin 2 showed unilateral cleft lip, aberrant right subclavian artery, and a persistent left superior vena cava. Of course, none of these were possible to diagnose at 12 weeks. Now we had a challenge. It's monochorionic twins, and we were fearing if one of the twins was having a major abnormality chromosomally, then what do we do with the rest of this pregnancy? So we did an amniocentesis, again from the sac containing the affected fetus, and this chromosomal microarray is normal. It's low resolution microarray that is normal. So any comment with that practice again?
I would have quietly looked at the genitalia to understand if the sex is the same or different.
Right.
Okay. And secondly, I presume you did a repeat test because DNA was not available from the first test.
Absolutely.
But actually in a CVS, there's no reason for the DNA to be less. Lots of DNA. But maybe they don't save the DNA because, you know, there are lots, the load is a lot.
Right.
But usually
So if I interrupt here, madam, if we send a CVS sample, we can tell the lab to store it.
Yes.
And how long can they store it?
That we store it for 20 years. We've never thrown away any
So it's fine, isn't
DNA sample in our life because they are genetic disorders.
Yeah.
You don't know when you need it.
When you need them.
Yeah? But they are labs, they are bigger, so it depends upon their policy. But I can understand if the DNA finishes from an amniotic fluid sample, but it can't
Not
finish
from a
from a
CVS.
DNA, not from a CVS. If, you know, you've given them good quantity, which I'm sure everybody does because you're such experts. So here, the chromosomal microarray is normal, which tells us that there is no structural or numerical abnormality of the chromosomes. That is worth reporting. And I would not do any further test because there is no major abnormality. Everything is treatable after birth, and therefore you would just counsel the family saying that you can't test for everything, this is fine, meet the surgeon and just follow the pregnancy.
Absolutely, yeah.
So, so here the low resolution was done. What, did we have got any further information?
This must be a 750K, I can't read.
No, 315K. This is not 750.
Acha. But why would you send that? So I'll tell you the difference between the two. This is a Affymetrix platform. I can't read what they... No, I don't see the methodology here.
Altium,
which one is it?
Yeah.
I don't know what they use, but what I know about are two platforms, the Agilent and the Affymetrix, okay?
It says AM, that means Affymetrix.
Where is
AM.
it?
Affymetrix, I think.
Affymetrix, yes.
Yeah.
Where have they written it?
No, it just
No,
says
it's not written here because it's the indication. On the other page, there would be the methodology.
Dasti boss, can you elaborate? Madam is asking which technique they have.
Is it Affymetrix platform?
Which platform have you used for this?
Affymetrix. Madam, we have used Affymetrix.
The Affymetrix. So usually, the difference between the two platforms is that the 750K has, you know, probes and it has little snips. It covers many more areas, and even the newer everything is being identified more and more, and even the newer microdeletion syndromes are being identified, whereas the lower platform just has probes, okay? So maybe some of the newer microdeletion syndromes are not there, but in the same breath, let me say that there are many centers that use the lower platform to reduce the rubbish, to reduce the noise, and to give things which are pathogenic and likely pathogenic. Yeah. In my hospital, we use the 750K because we are adept at reducing the rubbish, even though my lab will report it. But then I discuss with them and I, you know, say, okay, this is not significant. Because otherwise you will be doing many tests on the parents and it just doesn't stop, you know. So you're quite okay and you counsel your family that this is the maximum we can do. We can't test for everything. And that's what I tell them. I said there will always be a 1 to 2% risk. See, remember before this era of genomic testing, 97% of the babies were born normal. Okay. We are seeming to forget that now, I feel. Because we do many more tests. But yes, of course, we have to move with the times. But Beyond this, we don't do too much.
So you wouldn't advise a whole exome?
Not at all.
Yeah, that was the, yes. So I think if there are no burning questions anymore, we'll summarize the...
Ma'am,
yeah, Nitin has a question.
Ma'am, so it's a practical I have a patient, I have a couple. They had the previous pregnancy where the baby was thalassemia major. We know the mutation. For this pregnancy, IVF was done and pre-PGT M was done. And the embryo which was being transferred was normal, no mutation. So now the lady is around 9 weeks. Shall we confirm it by amnio or CVS, or we can rely on?
No, it's a screening test. You should confirm it, and usually an amnio is good enough. You don't need to do a CVS because we don't expect it to be incorrect. So it depends upon the expertise of the person. If you're an expert at CVS with the 1 in 1,000 risk of miscarriage, do a CVS, otherwise an amnio at about 17 weeks.
So even for monogenic disorders?
For
PGTM talk.
No, confirmation.
Yes.
Yes. All your guidelines say that it must be confirmed. It's a screening test. It's like an IPT.
No, ma'am, but they say that there is a difference between PGT-A and M.
No. The difference is PGT-A, you are doing a routine screen for chromosomes with no family indication. PGT, SR and M is specific to a family indication, and for all forms of PGT, M and SR, you must confirm.
Even we know the mutation we have done for that particular.
Yes, because it's a screening test. You know? No, it's not a part of the test. Then you have to order the A along with the SR. Yeah. They're two different tests. The technologies are different.
Okay, thank you so much, madam, for all the clarifications here that we have, and we end this session.
Thank you, Rohit, whom I have seen from his internship days. When I was a pool officer, when I came back from UK, then Rohit was an intern. And now I see him not only as a full-blown fertility specialist, not only of Kolkata fame, but of national fame. Thank you, Rohit. Come over here, please. Seetha, you all know. And Kanchan, many of you don't know probably that Kanchan had worked at IF, for a name it was at that point of time, for a number of years, and then had moved on, and he has really made a name for himself. Thank you, Kanchan, for coming here and gracing the occasion. Thank you, Seetha. Thank you, Rtna ma'am, for coming all the way from there. And I'm really thank you from the core of my heart, and give a big round of applause to Rtna Duapuri ma'am, who has come all the way and is going to travel back tomorrow early in the morning when we'll be still in bed, and she has to wake up at 4 o'clock in the morning to catch the flight. Thank you, ma'am. Let's have a photo. Invisive photographer. Now, the last but not the least, I would like to invite Mr. Dasti. He is actually Mr. S. Dastidar, whom we call very fondly Mr. Dasti, who is the director of Lilac Insights, and he is a strategic partner of this meeting today. Dasti, he comes from a technical background and then moved on to the management. He started his life as from Perkin Elmer, where I met him first, and we traveled to Mumbai about, I think, 12 years ago. And from then on, he moved on and started this Lilac Insights, which is doing very great, quite great in India. And we are very fortunate, Shubhamoy, his full name, that you have partnered with us, and thank you for this evening, lovely evening. I would like you to say a few words. Thank you.
Thank you, sir. Good evening, doctors. So, see, I'm from East. I was born in Chhattisgarh, but brought up completely in Calcutta. And today, when I see this program, it gives me lots of emotion. Because I remember my first meeting with Dr. Kusha, when I joined Perkin-Elmer, and I talked to him about fetal medicine. So sir said that, look, I had got trained under Kipros from London. I came back and I put a I remember sir, you saying that I put a fetal medicine board, fetal medicine. And later on, I think that there was, the awareness with the doctors were not there. But today I'm seeing it's completely changed, sir, that whole scenario. And we are very proud to be associated that what we started, that fetal medicine was in India, I think with doctor like Dr. Kusha, then Dr. Suresh, Dr. Pratima Radhakrishnan, Dr. Anita Kaul. These are the ones who started the awareness, and today we have seen a complete sea change of fetal medicine. And I'm very proud to be associated with IFM, extremely proud and associated with Dr. Kusha as my elder brother, my guru. And I find he's one of the most, kind of a inspiring personality for me whenever I meet him. So this program was a very good success. It's a lot of good medical activity that has led medical content wise. It was extremely good. And thank you. And I wish tomorrow next time we'll do a much bigger program with IFM. Thank you.
Thank you, Dasti. Thank you all of you for coming today. And I welcome thank all the 200 plus delegates who had come out of their busy schedule and come out of their family time and spend time with us. I hope we have been enriched. And I'm really, really thankful to all my faculties in IFM. Can I call the staffs over here? Daljit ma'am, where is she? Can you bring all the staffs over here for the last photo session? I think we have closed the scientific. Please enjoy your drinks, enjoy your dinner, and be free, and all the staff, so that we can have a picture, because this would be a really memorable moment. We had a picture of all the doctors, but we can't do without the staff. With all the receptionists, with all the telecallers, with all the typists, with all the management people, everybody, all the blood sampling people, please come over. Our coordinator, our invasive coordinator, our non-invasive coordinator, our watch time so that the patient waiting time is not increased. So these are the battalions we have. That's it. We have 1 or 2 guys here also. Don't think that we are only dealing with women. So please come over. I think we are missing few. Another 3 or 4. Odike ja. Please. Geeta kotha hai? Priyanka, come over. They are the backbone. And they have put in tireless work for every day, from day to day they put in. And IFM can't run without their oil and grease. And they don't receive any direct reprimands from me, because I have somebody who reprimands them. So Daljit ma'am, please come over. You are an integral part. Because truly speaking, I don't know much of what is happening in IFM on a day-to-day practice. So this is all being done by them. আমি একটু স্থান পেতে পারি ওখানে? And I can tell you they are all jewels in their own field. When they come, they are very naive. They don't know most of the things. And then we put them into different roles and we find out where they excel. So wherever they excel, we just keep them there. So that's how they love their job and they stay on. Thank you. Thank you, ladies and gentlemen. Thank you very much. Thank you, Neeta. Thank you, Ashita. Thank you, Vrunda, who have come all the way from Delhi, from Patna, from Ranchi, from everywhere to be with us. And thank you for outstation guests like Sushantada, who has come from Bardhaman. People have come from Midnapur, Asansol, wherever. And thank you very much. We close the day here. Thank you. Please enjoy your dinner. Thank you.